Hello everyone. Good morning. Good morning all of you. I guess I'm visible, audible. A very good morning to all of you. So, a new day, a new morning, new targets. So, can we start? Are you people there? Good morning Kuldeep. Good morning everyone. I'm clearly visible, audible. Can we start the session ahead? Okay. Good morning everyone. Good morning. So, I welcome you all for today's session. I am Dr. Priyanka Sachdev here, and today I am here to continue my series that is Super Simplified Pathology. Few days back, we have already started this series in which I am going to give you a crisp review of entire pathology in the most simplified manner. And I can assure you that your maximum MCQs from pathology, whatever exam you are targeting, the medical aspirants, like you are targeting the FMG, you are targeting the NEET PG, or else you are preparing for your university exams of MBBS. This session is going to be super useful for you. Okay, so without wasting any further time, we should continue the session. So I guess we have the two sessions are already available on this YouTube channel. Okay, the general pathology is completed, the hematology is completed. Regarding systemic pathology, these are all systems in your syllabus. So you have these 12 systems in your syllabus. But the last time I covered only 7, and these 5 systems were pending in the last. Okay, if you are looking for all these systems, you can look for the old YouTube link. It's available on this where you are watching now, on this YouTube channel only. The links are available, so you can watch the remaining systems there. You can watch general pathology and hematology also there. So currently I am going to cover the pending systems which I left pending or incomplete the last time. So basically, renal system, respiratory system, male genital, female genital, and musculoskeletal. We are going to cover these 5 systems one by one. Okay, so I will start with the renal system, the ultra important, the most important and most difficult to understand. But I assure you, I promise you, after this session, these systems will be fun for you. Like it will be it will be cakewalk for you. So after this, you can read Robbins like anything. Everything you can understand very easily. So can we start? Can we go ahead? Okay. So let's start with renal system first. In the renal system, what I'm going to teach you all important topics here. Let's start with the first most important topic here, glomerulonephritis. Can I start with glomerulonephritis? Can I start? So let's start with pathogenesis, classification and details of all type of glomerulonephritis. Now there is no exam paper in this world for the medical aspirants from pathology where you don't get a question of glomerulonephritis. It's the ultra super duper important topic for all exams. Okay, but the thing is that you should understand the basics. So let's start with the basics. Let's start with the glomerulonephritis. Let's start with the anatomy of the kidney. We know humans have a pair of kidney. Okay, we all have pair of kidney. Kidney is a bean-shaped organ, you can see, and this portion is known as hilum of the kidney. From the hilum of the kidney, the renal artery is going in, the renal vein is coming out, and ureter is coming out. So 3 things are there at the hilum: renal artery, renal vein, and ureter. This point is known as hilum of the kidney. Okay, anatomy I guess you already know. Now the structural and functional unit of the kidney is nephron. Humans have a pair of kidney, I told you. Each kidney contains nearly 1 million nephron. Okay, so humans have nearly approximately 2 million nephron, and nephron is the structural and functional unit of the kidney. Inside each kidney, you can see millions of nephrons are there. Now in the nephron, let's take one nephron. Let's take at the level of the nephron. Okay, at the level of the nephron, there are 5 parts in the nephron which are in front of you. So there is a Bowman's capsule, the first thing, then proximal convoluted tubule, which is known as PCT. Proximal convoluted tubule. Then there is loop of Henle. In the loop of Henle, there are 2 limbs: descending limb, ascending limb. After that, there is DCT, distal convoluted tubule, and in the end there is collecting duct. Okay, so these are the 5 parts of the nephron you can understand. To understand glomerulonephritis, we must understand the anatomy of this Bowman's capsule. What is glomerulus? So what is present inside this Bowman's capsule? We should understand that. If we can understand what is present inside this Bowman's capsule, we can understand the glomerulus. So these are the 5 parts of the nephron in front of you. You can see the glomerular capsule or Bowman's capsule, PCT, loop of Henle, DCT, and collecting ducts. These are the 5 parts. Let's start with glomerulus. Let's start with glomerulus. What is glomerulus? So, okay, let me draw it for you. Let me draw it. So, what is Bowman's capsule? I am drawing a Bowman's capsule for you. This is a Bowman's capsule. It is a capsulated structure, a cup-like structure, and it is continuing in PCT. It's like this, and after this it will continue in PCT, proximal convoluted tubule. I guess everyone agrees. Now what does this cup contain inside? इसके अंदर होता क्या है? What does it contain? So it contain, okay, this is the renal artery. There are many branches from the renal artery. The final branch is the afferent arteriole. The afferent arteriole is coming, forming a tuft of capillary and leaving as efferent arteriole. Okay, I repeat my words. I repeat. You have to understand this if you want to understand glomerulonephritis in detail. So this is afferent arteriole which is coming inside, and after that it is forming a tuft of capillary and leaving back as efferent arteriole. I have drawn only one capillary. There are bundle of capillaries, but to understand we have drawn only one. Okay, so you can understand here there is a capillary inside the Bowman's capsule. There is a capillary. Now whatever blood is coming here, in the blood there are certain substances present in the blood which we want to excrete in the urine. These are the excretory substances. Okay, so whatever things want to get excreted in the urine, they will come here, filter here, and they will accumulate in the Bowman's space. They will accumulate in the Bowman's capsule, and they will go ahead in the PCT, DCT loop of Henle, and finally they will be excreted in the urine. This is normal physiology. So we will understand anatomy, physiology, then we will come on pathology. You got it? Are you people there? Can you write down something in the chat box? Just a second, let me see if I can see your chat. Yes, I can see your chat, I guess. Okay, yes, so you can see. Okay, so this is the afferent arteriole. The blood is coming. From the blood, whatever substances which are supposed to be excreted in the urine, they will filter. This is known as glomerulus filtration. Okay, glomerulus filtration. They will accumulate here in the Bowman's space, and they will pass in the PCT, loop of Henle, DCT, finally in the collecting duct, and they will form the urine. Okay, so this is the thing. So my point is that this, suppose here is a substance, so it want to get filtered and excreted. So how many layers it has to cross? How many layers it has to cross to go in the Bowman's space? So let me draw this diagram again. So let me draw this Bowman's capsule. Okay, can you see the two layers in the Bowman's capsule? Bowman's capsule have two layers. Okay, this layer is known as parietal epithelium. Here I am drawing parietal epithelium. This one is visceral epithelium, and this one is parietal. The outer one is the parietal epithelium. The blue one is the parietal. The green one is the visceral. This is the lining of the Bowman's capsule. It is epithelial lining. Now I am drawing the capillary. You all know this is afferent arteriole coming, forming a capillary and going back as efferent arteriole. So let me draw the double lining, the lumen of the capillary. This is the capillary. So you all got it. This is afferent arteriole and this is efferent arteriole. Now all capillaries are lined by endothelial lining. So let me draw one of the endothelial lining. So here we have endothelial lining, and this is the basement membrane of the capillary. So basically any substance present here, any substance which is present in the lumen of the capillary, and it has to come here in the Bowman's space, it has to cross three things. One thing is the basement membrane at the center. Can you see? This is the basement membrane of the capillary at the center. On one side it's endothelium, on other side it's epithelium. I repeat, there is a basement membrane. On one side it's endothelium of the capillary, on one side it's epithelium. Which epithelium? It's visceral epithelium. The visceral epithelium, the green color epithelium. And finally, this is known as filtration barrier. So my point is that the filtration barrier have three things. In the center, there is a basement membrane. This is the basement membrane of the capillary, basement membrane. On one side, there is endothelium. You can see this is endothelium. And on one side, this is epithelium, the visceral epithelium of the Bowman's capsule. The visceral epithelium, the shape of the visceral epithelium is like the foot. Have you seen your foot? See, the foot is like this. We have the toes, the fingers. So it is like that. That's why it is known as podocyte. Podo ka matlab hota hai foot. Podocyte. You got it? So this is filtration barrier. So any substance present here, it will pass and come here and accumulate. So this is the lumen of the capillary. And here is the lumen of the Bowman's capsule. So finally, the substances are passing like that. Say yes. This is filtration barrier. Does everyone got it? Anyone having any doubt? So if you got what is filtration barrier, now if any injury occurs to this filtration barrier, this is known as glomerulonephritis. So let's start glomerulonephritis. Now you can understand well कि glomerulonephritis होता क्या है. For the students who didn't got it, finally I am repeating it once in just 1 minute. Listen everyone here. So I am drawing a Bowman's capsule. You know what is nephron, I guess. So I'm trying to draw a Bowman's capsule in front of you. Bowman's capsule have two linings. What are the two linings of the Bowman's capsule? Both are epithelium. This one I'm drawing now in the form of the foot, the foot-shaped processes. This is known as visceral epithelium. Okay, and this one I'm drawing one more here. This one, the outer one. This one I'm drawing with purple color. You can see the colors. Okay, this one is parietal epithelium. Okay, the parietal epithelium is flat, but the visceral epithelium, the shape is like the foot, है ना, पैर के जैसा, foot के जैसा. That's why known as podocyte. These cells are known as podocytes. Okay, now from inside it, I would like to draw a capillary. So let's draw a capillary like this. Okay, this is a capillary. Now you can understand, one is afferent arteriole, one is efferent arteriole. I'm drawing like this. Okay, this is the capillary, you can see. So this is afferent arteriole coming and efferent arteriole leaving. So the capillary have the endothelial lining. So let's draw the endothelial lining of the capillary. This is the endothelial lining, and this is the basement membrane of the capillary. This is the basement membrane. So let's take a substance. This is the substance. It want to get excreted and pass over here and collect over here. So what three things it is passing? First, it is crossing, see, the endothelium, then basement membrane, then epithelium. So these three things form the filtration barrier. In the center, there is a basement membrane. On one side, it's endothelium. On one side, it's epithelium. In the epithelium, it's visceral epithelium is coming in the filtration barrier, not parietal epithelium, to be crystal clear. You got my point. Can we go ahead? So this is the filtration barrier. There are three things: basement membrane in the center, endothelium on one side, and epithelium, the visceral epithelium on other side, which is known as podocyte. Okay, so this is the thing which I'm telling you. You all can see the Bowman's capsule, the same diagram I have drawn for you, and you can see the capillary. This is afferent arteriole, and you can see this is efferent arteriole. I have explained you. And this is the capillary. In the capillary, we have a basement membrane shown by black color and the endothelial cells shown by the red color. And this is the filtration barrier. The substance here passing to here, crossing three things. I guess everyone got it. So this is the basic diagram. Now in this diagram, I am going to teach you 9 types of glomerulonephritis right now in a comparative table. So if you understand this master diagram, the glomerulonephritis will be fun for you. If you don't understand this, the rest 9 of the glomerulonephritis, you will not get anything. So this is the basic. What you are getting in this diagram? What you are getting in this diagram? Thank you so much for all your feedback. Thank you. And Dr. Surya, definitely I will take microbiology here also on the YouTube. I will try my best. Okay, so listen. So in this diagram, I can see multiple capillaries. Can you see? Okay, how many capillaries you can see? I can see this is one lumen, this is another lumen, this is another lumen, this is one more lumen. I can see 4 or 5 luminated capillaries. I told you in the Bowman's capsule, it's not one capillary. There are multiple capillaries in the tuft. So few capillaries are shown to you. And what is this yellow cells outside? Can you see yellowish cells outside? Outside, covering all the capillaries. It's parietal epithelium in the Bowman's capsule. It's parietal epithelium. Now you can see the innermost layer of the capillary is fenestrated. Can you see the holes fenestrated? It's endothelial lining. The endothelial lining is fenestrated. In between, the pink color, a thin pink color membrane is the basement membrane. And on other side, you can see the podocytes. On other side, you can see these foot-shaped processes are the podocytes. Okay, and the green cells are the mesangial cells. What are mesangial cells? Mesangial cells are the supporting cell. Let me draw this diagram for you. Let me draw. So what is this diagram? I have cut the Bowman's capsule from here and looking from above. So if I cut, imagine this is the Bowman's capsule. Let me draw a Bowman's capsule. Okay, this is the Bowman's capsule. It contains the capillaries multiple like that. Okay, if I'm cutting it from here and looking from above, what I will see? So see, I will see the parietal epithelium outermost. These are the cells of the parietal epithelium, okay, covering from all sides. This one, the parietal epithelium, okay. Inside that I can see multiple capillaries. I am drawing 2, 3. Okay, the capillaries are lined by endothelial lining, which are fenestrated. Okay, this is the fenestration, endothelial lining. Okay, and basement membrane also you can see. This one is the basement membrane of all the capillaries. And outer to this we have visceral epithelium, visceral podocytes. These are the podocytes I am drawing. So you can see the filtration barrier in all the capillaries. In all the capillaries, you can see the 3 colors: the red, the green, the blue. The red, the green, the blue. The red is the endothelium, the green is the basement membrane, and the blue is the podocytes. And apart from that, we have supporting cells in between. Jo space bach gaya na, whatever space is left, we have these supporting cells. These supporting cells are known as mesangial cells. Everyone who is watching me live, give me a thumbs up right now if you got this orientation. You got this orientation, what diagram I tried to draw for you. I have drawn multiple capillaries inside the Bowman's capsule. I have shown you parietal epithelium inside which multiple capillaries are there. In each capillary, 3 lining. The central is the basement membrane. On one side endothelium, on one side visceral epithelium, that is podocyte. Now if any substrate is present in the lumen of these capillaries and it try to come out, so it has to cross the 3 layers everywhere, and it will collect in the mesangial space. Everyone give me a thumbs up. Okay, got it. Can we go ahead? Can we go ahead? So this is the diagram, okay, from the Robbins itself. Now we will understand glomerulonephritis. You can easily understand. So if there is an injury to the filtration membrane, either of the three things, either the basement membrane is injured, or endothelium is injured, or epithelium, the podocytes are injured, the disease is known as glomerulonephritis. Now there are three mechanisms, actually three type of injury. Who is causing the injury to the filtration barrier? It can be antibody who is causing the injury. It can be CD4 and CD8 T lymphocytes who is causing the injury. It can be complement, you know, C1 to C9 complement pathway is present in human blood, that is causing the injury. If the complement is causing the injury, it is known as alternate pathway. If the CD4 CD8 T lymphocytes are causing the injury, it is known as cell mediated. And if the antibodies are causing the injury, it is known as antibody mediated. So there are three things. So let me draw it for you again. So this is the basement membrane. Now this diagram I am going to draw at least 100 times in this session. This is endothelium on one side, and this is podocytes or visceral epithelium on another side. This is filtration barrier. Now who is causing injury to this? Maybe the injury is causing the antibodies, maybe the injury is causing CD4 and CD8 T lymphocyte, or maybe the injury is caused by C1 to C9 complement. So three things can cause the injury. This is antibody mediated injury, this is cell mediated injury, and this one is alternate pathway. Alternate pathway means complement mediated injury. So start from the basics. Okay, let's take antibody mediated, which is further of two types. Okay, let's take antibody mediated in detail. Cell mediated alternative pathway, we will not see the details, but antibody mediated is further of two types. Okay, further of two types. Okay, I would like to explain you what are the two types of antibody mediated injury. Is it in situ formation, in situ immune complex formation, or circulating immune complex formation? If it is in situ, it is again of two type, fixed antigen, planted antigen. If it is everything is going bouncer to you, na, give me just 2 minutes, I will explain you everything. Just give me 2 minutes. Let me draw three human bodies for you. I'm drawing a just sketch diagram. So just sketch diagram to explain you the mechanism of antibody mediated injury. Antibody mediated. Okay. Okay. So can you see here I am drawing the kidneys and all of them. I'm drawing only one kidney to explain you. Okay. This is the blood vessel. This is the blood vessel of all the human beings. Okay, now what can happen? There can be three possibilities by antibody mediated injury. Now inside the kidney there is filtration barrier. Now let me draw filtration barrier in all of them. This is the basement membrane I am drawing. On one side there is endothelium. This is the endothelium I am drawing in all of them. This is the endothelial lining. And on other side I am trying to draw the visceral podocytes, the epithelium. I am trying to draw the filtration barrier in all the kidneys. All the kidneys have 1 million filtration barrier. I have drawn only one. Now listen, what can happen now? Sometimes body form antibodies against the basement membrane. The basement membrane is made up of collagen. What does the basement membrane made up of? Collagen. Sometimes antibodies are formed anti-collagen. It is an autoimmune disease, right? It is an autoimmune disease. So antibodies are formed. They will come and they will destroy the basement membrane. Out of the three filtration barrier components, the basement membrane is completely destroyed. It is known as where the antigen antibody complexes are formed. They are formed in blood or they are formed in kidney. They are formed in kidney. In this case, they are formed in kidney. So in the blood, the body is forming antibodies, and these antibodies are coming and binding with the antigen. The antigen is already fixed there. The antigen is fixed. What is the antigen? The antigen is the collagen, the basement membrane collagen. It is known as fixed antigen. What is the antigen? The antigen is fixed. It's the collagen. And the antigen antibody complexes are formed in situ. In situ ka matlab hai they are formed inside the kidney, not in the blood. So this mechanism is known as in situ antigen antibody complex formed against a fixed antigen. This is the first mechanism. Second mechanism, imagine. You have to imagine. What you have to imagine? Imagine in the blood there is a bacteria. There is a bacteria. The person have pharyngitis, tonsillitis, and the bacteria is going in the blood. This can happen. The bacteria is going in the kidney and getting deposited over the podocyte, right? So this antigen is known as planted antigen. What it is known as? It is planted there. It was not initially present. It is a planted antigen. It is a bacteria which is planted. It is planted. Now the body is again forming the antibodies against the bacteria. Okay, the antibody will go behind the bacteria. Where the bacteria is going? On the podocyte. The antibody will also go on the podocyte and form complexes there. So here also the complexes are not formed in the circulation. The complex are formed in situ only. In situ means inside the kidney, but in situ against a planted antigen. Here in situ complexes are formed against a fixed antigen. The antigen was already there, fixed there. And it is an autoimmune mechanism. Here the antigen is planted there, right? See the third and the last possibility. In the third and the last possibility, again a bacteria is there in the blood. Okay, in the blood the person have some bacterial infection or what. Here also the body is forming the antibodies, but antigen antibody complexes are formed in the blood itself. in the blood itself, and as it is the complex is coming and depositing over the filtration barrier. So here the complexes are formed in circulation, not in situ. The complexes are formed against circulation, so circulating complexes formed, right? Here fixed or planted ka chakkar nahi hai. So there are three different mechanisms, and all of them the destruction is caused by the antibody, but the mechanism is different. I tried my best to explain you the three mechanisms. Give me a thumbs up if you got the orientation, what I am saying. So in all of three, who is causing the destruction? You will say, ma'am, antibody, right? But what is the mechanism? In the first case, who is the antigen? The antigen is a fixed antigen. By fixed antigen, I mean the collagen of the basement membrane. So it is an autoimmune disease in which the body is forming antibodies against the collagen of the basement membrane and causing the destruction. So it is known as in situ complex formation. Antigen antibody complexes are formed in situ inside the kidney only against a fixed antigen. Say yes. In the second case, in the second phenomenon, the bacteria is present in the blood. The bacteria is coming first and getting deposited, and behind the antibody is coming and getting deposited. So again antigen antibody complexes are formed in the kidney, that is in situ complexes formation, but against a planted antigen. We have planted antigen there, it was not initially present. And the third case, the bacteria is present in the blood, the antibody also formed in the blood, and antigen antibody complexes are formed in the circulation itself, and complex is coming and getting deposited. You have to understand the difference between these two. Okay, here the bacteria was deposited and then antibody is deposited, so complex is formed in the kidney. And in the third case, antigen antibody complexes, bacteria and antibody, they are forming the complex in the blood itself, or blood mein se aanke kidney mein deposit ho raha hai. Say yes, I'm trying hard. If you read all these directly from Robbins, now everything will be bouncer. But now try reading. It will be fun and cakewalk for you. Believe me. Got it? So that is the three type of mechanism what written in front of you. So either it is in situ complex formation or circulating complex formation. If it is in situ, it can be a fixed antigen. By fixed antigen, I mean the collagen. And it can be a planted antigen. The planted antigen, I mean a bacteria which is coming and getting planted over the podocyte. Right? Okay. So the same three diagrams from the Robbins in front of you. You can see this one. You can see this one. You can see this one, right? You can see the lumen of the capillary in all of them, and I guess you all can see the filtration barrier. You all can see the filtration barrier in all three diagrams. Try to see the filtration barrier in the center. See this basement membrane here, see this basement membrane here, see this basement membrane here. Now see, inner side is endothelium, outer side is podocyte. You can see, right? Now in the first, you can see the lumen. See the lumen. The lumen contain antigen antibody complex itself. Lumen के ही अंदर दिख रहा है. देखो, antigen is red color. You can see the antigen is a red color bacteria, the dot, and the antibody is shown by black color. You can see the black color. This is the antibody. So complex is formed in the circulation, and complex is coming and getting deposited here. So this one is circulating one. Circulating complexes formation. See the second diagram. In the second diagram, the lumen is showing only antibodies. Okay, so it is only antibodies are coming and getting deposited over the basement membrane, over the collagen of the basement membrane. So it is the fixed antigen. And in the third scenario, again the lumen contain only antibody. Here also only antibody, here also. So here also the complexes are formed in situ. These both are in situ, right? But here the antigen is not the collagen. The antigen is present something on the podocyte. It's a bacteria which get planted on the podocyte. So this one is planted. I tried hard. Come on, I really tried hard to explain you this, right? So every time I try to make it more simple. The many times I teach students, I try to make it more simple. You want me to say it again? Okay, I will say it with a different way for the students who didn't got it, just in 1 minute. I will not take much time. Let me draw 3 filtration barrier only. Now you don't imagine 3 filtration barrier. You imagine 3 human beings in front of you. You imagine the kidney of these human beings. Inside the kidney, you imagine 1 million nephron, and inside 1 million nephron, the 1 million filtration barrier. You imagine that. I'm drawing only 3 filtration barrier in front of you to explain you the 3 mechanism in short again. Okay, what can be the 3 mechanisms? Can you please tell me? Can you please help me? In the first mechanism, what I'm saying, let me draw the antigen with blue color. Who's the antigen? Here in the first mechanism, the antigen is the collagen of the basement membrane. See where I'm drawing the dots. I'm drawing the dots in the basement membrane. The collagen of the basement membrane is acting as a antigen. So where are the antibodies? The antibodies will be formed in the lumen. You can see this side is lumen of the capillary and this side is the lumen of the Bowman's capsule, right? So antibodies are formed in the blood. In the lumen of the capillary, they will come and they will bind here. They will form antigen antibody complexes in the basement membrane. So here you can see the complexes where they formed. You will say, ma'am, complexes are formed in situ. In the blood only antibodies are there, complexes are not there. They are formed in situ and they are formed against a fixed antigen. So antigen is fixed and complexes are formed in situ. This is the first mechanism, we are done. Come on, the second mechanism. In the second mechanism, who is the antigen? The antigen is present in the blood. It's a bacteria. The bacteria will first come, get deposited over the podocyte. Pehle bacteria aaya. It will come and deposit over the podocyte. Now, piche, the bacteria is already deposited. There is no more bacteria. Let me rub the bacteria here. Let me rub the bacteria. It is already deposited. Now the body will form the antibody. So this is the antibody formed again in circulation, and antibody will come piche behind the bacteria. It will also deposit over the podocyte like this. So again you will say, ma'am, antigen antibody complexes are formed in C2 only, because in the blood we have only antibody. They come and deposit here only. But here the antigen was a planted antigen. First we have planted a bacteria, and then antibody is coming piche behind. So this is the second mechanism. Both of them are in situ, because in the blood you have only antibodies. And in the third scenario, you got it. There is a bacteria in the blood. This is a bacteria in the blood. The body is forming antibodies against the bacteria. These are the antibodies are also formed in the blood. So antigen antibody complexes are formed in the blood itself. Come on, see the antigen antibody complexes. Now see the three scenario. Here only antibody, here only antibody, here the complexes are formed in circulation. So this mechanism here, the antigen antibody complexes are formed in the circulation itself, right? And here antigen is not fixed and planted. It's a simple antigen. We cannot say whether it is fixed or planted. So these are the three mechanisms, crystal clear in front of you. Can we go ahead? Now, where are the location of these deposits? I call deposit. Now you got what is deposit. Whenever I say the word deposit, I mean an antigen antibody complex. What does I mean? I mean an antigen antibody complex. I have drawn the three diagram now. It will not come again. So where does the three, in the first scenario, it was on the basement membrane. In the second and third scenario, it was on the podocyte. So it can be anywhere on the three components. So what are the four location of the deposits? So for that, we have to draw again the filtration barrier. There is a basement membrane at the center, endothelium here, and visceral epithelium or podocyte here. Not only this, we have mesangial cells also. These are the supportive mesangial cells all around. The supportive mesangial cells. Now say, where are the deposits? There can be four locations. The deposit can be in the basement membrane. See, I am drawing. These are known as epimembranous deposits. The deposits can be on the endothelium. These are known as subendothelial deposits. The deposits can be on the epithelium, right? Like epithelium. These are known as subepithelial deposits, and the deposits can be on mesangium. These are known as mesangial deposits. Come on, what are the four locations? Who will tell me? Epimembranous, subendothelial, subepithelial, mesangial. But deposit, I mean, I have drawn only dot, but actually it's an antigen antibody complex which is destroying the filtration barrier. So these are the four locations: subepithelial, epimembranous, subendothelial, mesangial. You got it. Can we go ahead? Can we go ahead? So the four deposits are shown to you in this diagram. Again, you can see the diagram. You can see the filtration barrier. See, tell me these. What are these deposits? Let me ask you. What are these deposits? Can you see? I'm drawing here with red color. These are present on the basement membrane. So these are epimembranous. Okay, what are these deposits? These one I'm drawing number 2 one, this one. So these are on the epithelial. So these are subepithelial, subepithelial. Okay, and subendothelial is not very clear here. You can see these are the mesangial in the center. Okay, so these are the four types of deposits. You got it. Now let's come on the various types of glomerulonephritis. How many types of glomerulonephritis are there in our syllabus? There are 3 types of glomerulonephritis: primary, secondary, and hereditary. Okay, there are 9 types of primary glomerulonephritis I am teaching you right now. I will give you 5 minutes on each of them and we will finish all primary. In the secondary, there is a big list. What do you mean by secondary? Here the main disease is kidney only, glomerulonephritis. That's why known as primary. In the secondary, the main disease is something else, like the patient is having diabetes, SLE, something else. And kidneys involved here, of course, but secondarily. So here many diseases are there, but I will teach you only one: diabetic nephropathy. Diabetic mellitus mein diabetic nephropathy we will see. That is the ultra important secondary. In the hereditary, there are three. I will explain only one, that is Alport, right? So here all 9 we will explain. Here 1, here 1. So total 11 type of glomerulonephritis I am going to explain you right now. Give me a minute. Okay, so can we start the classification? So see how many primary are there. I am saying you 9 are the primary. So say the names now first. We will study all 9. Come on. But say the names. The first one is the post-streptococcal glomerulonephritis, known as PSGN. Also known as acute proliferative glomerulonephritis, APGN. So many students even don't know that PSGN and APGN, what is the full form, and if it is the full form, they know these two are same thing. So please learn PSGN and APGN एक ही बात है ना, और full form learn करो. It's post streptococcal glomerulonephritis or acute acute proliferative glomerulonephritis. The next is rapidly progressive glomerulonephritis, RPGN. RPGN, you have to learn these short forms. The next is MCD, minimal change disease. Okay, the next is membranous and membranoproliferative. Agle do saath mein lungi. I will take the next two together. Let me explain you. Membranous glomerulonephritis and membranoproliferative glomerulonephritis. I will take these two together because they are related somewhat. Okay, the next two again I will take together. Focal segmental glomerulonephritis and focal segmental glomerulosclerosis. I will take these two together. And last may two more, IgA nephropathy and chronic glomerulonephritis. So these are the 9 type of glomerulonephritis in your syllabus. Okay, the primary one, we will make a comparative table between all 9. I want you to make this table with me right now watching this video live. Okay, can we go ahead? Coming on the secondary glomerulonephritis. Secondary, I told you there is a big list. So here the kidney is involved, the glomerulus is involved, but secondarily, not primarily. So it can be SLE, it can be diabetes, it can be amyloidosis, it can be PAN, it can be Wegener, it can be Goodpasture, it can be HS purpura, it can be multiple systemic infections, it can be idiopathic. But most important is diabetic nephropathy. So we will see the details only of diabetic. So I will teach you all 9 primary. Among the secondary, I will teach you diabetic, and among the hereditary, there are 3 hereditary glomerulonephritis. As soon as the child take birth, the neonate take birth, right? At the birth only the person have, the child have glomerulonephritis, it's hereditary. So there are 3 diseases under this: Alport syndrome, Fabry disease and Nail Patella. Among that the ultra important is Alport. You got my point? So let me explain you what we are going to do in the next 1 hour now. In the next 1 hour, I am going to teach you all 9 primary in a fixed set of headings in a comparative table. I will teach you 3 diagrams in each of them: the light microscopy of all of them, the electron microscopy of all of them, and immunofluorescence of all of them. You definitely get question from these in your exam, right? Whatever phase you are preparing, it doesn't matter. From the secondary, I will teach you the diabetic nephropathy. Okay, and from the hereditary, I will teach you the Alport. And in this way, we will finish the glomerulonephritis. After glomerulonephritis, few more important topics in the renal system like renal tumors I am going to teach you after this, and some congenital diseases like polycystic kidney disease and all. And in this way, we are going to complete the renal system first. Then we will talk about the respiratory system and others. So according to me now, whatever you are studying, study it in detail with clear-cut concept. It is not the thing that just superficially you are taking the things just for covering, you are covering and you are not getting it in depth. So according to me, cover if you are covering less, but it should be crystal clear. Okay, we will take a little bit more time, but we will make the things crystal clear. So can we go ahead? So I want all of you to make this comparative table right now with me, please. Okay, so the 9 type of primary. First, we will talk about primary glomerulonephritis. So the 9 type of primary glomerulonephritis are in front of you. The first is APGN, acute proliferative glomerulonephritis, also known as PSGN. Write down both names. Okay. The second is RPGN, rapidly progressive glomerulonephritis. The next is minimal change disease, MCD. The next is membranous membranoproliferative. We will take together. The next is FSGN and FSGS. This is focal segmental. This is also focal segmental. Glomerulonephritis, glomerulosclerosis. The next is IgA, nephropathy and chronic. So I will teach you all of them. The etiology. In the etiology, the pathogenesis, there are 3 type of pathogenesis now, whether antibody mediated, cell mediated or alternate pathway. I already told you now, alternate is complement mediated. If it is antibody mediated, it can be in situ, it can be circulating. If it is in situ, it can be fixed or it can be planted. So I will not teach you the entire mechanism. I have already discussed the pathogenesis. I will say only one word, whether it is antibody, whether it is cell, whether it is alternate. If it is antibody, I will say circulating or in situ. If it is in situ, I will say fixed or planted. So in the etiology, I will explain like that. Gross only one word wherever important. Otherwise, you can leave a blank space. If it is not important, don't write it down just for filling. Okay. Light. Now in kidney, we do 3 microscopes. Light microscopy, electron microscopy, immunofluorescent microscopy. Now the basics, student even don't know कि मैम हम 3 तरह की microscopy क्यों कर रहे हैं. So one of my student asked me, that's why I thought that this may be the question in your mind. Why we are doing 3 type of microscopy in kidney? Usually we don't do 3 type of microscopy. We do only light microscopy in all other organs. Now here we want to see the deposit. In light microscopy, you will see the histopathological H&E image. I will give you that pink purple typical image of all of them. In electron microscopy, you will come to know the location of deposit. Location of deposit. Okay, by location of deposit, I mean the 4 options. Whether it is epimembranous, whether it is subepithelial, whether it is subendothelial, or whether it is mesangial. So you have to write only one word. Whether it is subepithelial, subendothelial, mesangial, or epimembranous. You got it. I guess I told you the 4 locations. Okay, in immunofluorescence you will come to know the composition of deposit. Come on, not location, it's composition. So the deposit is made up of what? You will say, ma'am, deposit is antigen antibody complex. So I will ask you, what is antigen, what is antibody? So you have to specify it clearly. So that's why we are going to do the 3 type of microscopy. The light microscopy, that will give us HNE characteristics. The electron microscopy, that will give us the location of the deposit, and immunofluorescent microscopy, that will give us the composition of the deposits. So please, if your basics are clear now, the things will become super duper easy for you. So first learn the importance of the 3 type of microscopy, then start filling this table with me. I request all my audience which is watching me right now, which will watch me later, the recorded version, take out your notebooks right now at this instant. Take out your pens. Don't be lazy. Make this table with me. You will remember me, like when questions will come and you can revise the entire glomerulonephritis which is given in 100 pages in Robbins, you can revise in 5 minutes. Believe me, it will be like a magic. Please make it with me right now. Right, because later will never come. Before starting these 9 type of glomerulonephritis in this stipulated manner, I will take one and discuss like this. Okay, before that I will teach you 2 things, nephritic syndrome and nephrotic syndrome, because each of these glomerulonephritis will present the clinical feature, either nephritic. The last column you can add 1 more column here, clinical feature. Please add. So add etiology, gross, light microscopy, electron microscopy, immunofluorescence, and end may you add clinical feature. In the clinical feature, I will not teach you the clinical feature of all of them. I will say only 1 word. It presents as nephritic syndrome or nephrotic syndrome. So you have to write either nephritic or nephrotic in each of them, right? Or sometime 50-50%, both of them. So you should have an understanding, ma'am, nephritic ka matlab kya hai? Nephrotic ka matlab kya hai? You are saying it is presenting as nephritic, this is presenting as nephrotic, hai na? What do you mean by that? So first we will see what is nephritic syndrome, what are the clinical features under that category, what is nephrotic syndrome, what are the clinical features under that category. So if I say nephritic, you will have an overview, ma'am is saying what. You got my point? So let me tell you what is nephrotic syndrome, and then we will start this table again. Okay, that is the clinical presentation we are talking in general. Okay, of all the glomerulonephritis. Some glomerulonephritis present as nephritic syndrome. Some glomerulonephritis present as nephrotic syndrome. So I mean to say nephrotic syndrome is not one disease. It is an umbrella term having multiple disease under it. Nephritic and nephrotic syndrome have a common collection of clinical feature. If I say nephritic syndrome, I mean these 5 clinical features. The patient is presenting with these 5 clinical features. If I say nephrotic syndrome, the patient is presenting with these 6 clinical features. So it is a collection of clinical features. It's a syndrome. Okay. So let's start with nephritic syndrome. In nephritic syndrome, patient will come to you with hematuria. Doctor, I am having blood in my urine. Blood in urine is known as hematuria. Doctor, I am having red urine. I am having smoky urine. So, you know, sometimes it is microscopic. Okay, so that is hematuria, the first finding. In nephrotic, hematuria will never come. So in any of your clinical question, if it is mentioned the patient is having blood in urine, the patient is having Coca-Cola color urine, the patient is having red urine, the patient is having RBC cast in the urine, they are talking about nephritic syndrome. So from the 4 option, rule out nephrotic. Ab nephritic mein dimag lagao. So this is the approach. You got my point? So hematuria will always indicate nephritic syndrome, not nephrotic syndrome. Say yes. Okay, got it. So that is hematuria. Now coming on proteinuria. Okay, the second is the proteinuria. So proteinuria means protein in urine. Blood in urine, protein in urine. Here proteinuria is mild. The third is, just a second. Third, if you measure the blood pressure of this patient, it will be high. The patient will be hypertensive. The patient will have edema all over the body, especially on the face in the morning. Okay, and patient have oliguria. The urine is less than 400 ml or 500 ml per 24 hours. That is the definition of oliguria. So these are the 5 clinical features the patient will present to you: hematuria, proteinuria, hypertension, edema, oliguria. Can you say it out? Hematuria, proteinuria, hypertension, edema, oliguria. That is, this 5 collection together is known as nephritic syndrome. You got my point? That is the meaning of the nephritic syndrome. You got it? And I will draw the diagram also. I will explain you all 5 why it is occurring here in nephritic. Let me tell you the 5 features, the 6 features of the nephrotic, then I will draw the diagram for both of them. Let me come on the nephrotic syndrome. In nephrotic syndrome, there is no hematuria. There is only proteinuria. Proteinuria is common feature in all of them, in both of them. So proteinuria is rather massive here. Yahan pe jo proteinuria tha, that was mild. But here the proteinuria is massive. Okay. Proteinuria meaning again is same. It's protein in urine. It's the proteinuria, right? Now most of the protein is lost in urine. It's massive. So in the blood there is less protein. So less protein in blood. You will say, ma'am, both are correlated. Now, if you are saying more protein in urine, that's why there is less protein in blood. Yes, I agree. If there is more protein in urine, that's why there is less protein in blood. So both are the features. Massive proteinuria, that's why the person have hypoalbuminemia. Hypoalbuminemia matlab blood mein less albumin. Albumin is a protein. Okay, say yes. And edema is here also. We have edema. So edema is also a common feature, right? Now let's talk about the lipid. Lipid is more in the urine, more in the blood. At both places, lipid is more. I will tell you reason. Don't worry. Hyperlipidemia and hyperlipiduria. Both are the feature. So lipid is a feature of nephrotic syndrome, not nephritic. And patient have hypercoagulability, because of which multiple thrombus will form in the blood, multiple emboli can form in the blood. Hypercoagulability is a feature of nephrotic syndrome. Okay. So okay, Gayatri, I will tell you, I will give you the link to join the PSM classes also. So wait a while. I will teach everything. Don't worry. Step by step we will go. So in the next few days, I am launching PSM also. Don't worry. Don't worry. We will do everything. So okay. Okay. What you are asking, Osama, ma'am, in nephrotic syndrome, why not microscopic hematuria if in both glomerulonephritis? I am coming, Osama, on this point. Okay. So listen, what is the problem? The pathogenesis is different, Osama. So let me draw the kidneys. Here, let me draw kidney. This is the kidney. And this is the, sorry, how to draw it. Let me draw, these are the kidneys. This is the ureter. This is the urinary bladder. And this is the urethra. Again, let me draw the same to explain you the two, nephritic and nephrotic syndrome. What is the problem in nephritic and nephrotic syndrome? Let me draw the blood vessel. This is the blood vessel, renal arteries. This is the blood vessel, the renal arteries. Let me try. Okay, I'm also trying. Okay, so this is nephritic. I would like to try here. And this is nephrotic. I will try to draw here. I will explain you the 5 or 6 symptoms why it is here. So in nephritic, what is the problem now? Here the patient is having glomerulonephritis, here also, as Osama is saying. So the kidneys are failed. Because of the glomerulonephritis, I mean to say the kidneys are non-functional. Here the kidneys are non-functional. So what will happen? What is the function of normal kidney? Why God has provided you a pair of kidney? Come on. Why? To excrete the sodium and water and excretory products. Now if the kidney is non-functional, how the patient will excrete sodium and water? So patient will have sodium and water retention. You got my point? Because the kidneys are non-functional. Kidney is not excreting the sodium and water. It is non-functional. So sodium and water retention will lead to hypertension. You know, it will lead to edema also. More sodium in the body, more water in the body. So body will have edema, right? More water will cause hypertension. So hypertension is there. Edema is there. Okay. And since kidneys are non-functional, urine is not formed. So urine is not passing out. So patient have oliguria also. Since the kidneys are damaged here, Osama, the kidneys are damaged here. Now blood is leaking out in the urine. So patient have hematuria also. The blood is leaking out in the urine, the blood is coming. And normal kidney don't excrete protein. When they are healthy, they don't excrete protein. But here kidneys are damaged. The filtration barrier is damaged, so protein is leaking out. So mild, but mildly, है ना? So mild proteinuria is there. Mild proteinuria. Say if you got all the 5 symptoms, why they are occurring in nephritic. The main problem in nephritic, I must highlight, is sodium water retention. You can understand why there is sodium water retention. Say, everyone say. The main problem here is nephritic is the sodium water retention. Because the kidneys are non-functional, they are not excreting sodium and water. I mean to say, if they are not excreting, they are retaining. So they are basically retaining sodium and water. Say yes if you got it. So they are retaining sodium water retention is there. That is leading to all these systems, all these symptoms. Okay. Paras is asking to repeat. Okay. So here, Paras, listen. In nephritic syndrome, the kidneys are non-functional because there is a damage to the filtration barrier. What is the normal function of kidney? Why God has given us kidney? To excrete sodium, water and excretory products. Now here the kidneys are non-functional, so sodium water will not be excreted in the urine. Normally it is excreted. So sodium water will be retained in the blood. So in the blood there is more sodium causing hypertension, more water causing edema, right? And less urine will pass out. That is oliguria, right? And since the kidneys are damaged, the filtration barrier is damaged. Normal, when a healthy filtration barrier, blood and protein do not pass in urine. But here the filtration barrier is damaged to that extent that blood and mild protein is passing in the urine. That's why hematuria and mild proteinuria. Okay, can we go ahead? Okay. Okay. Now come on the nephrotic syndrome. The other side, the nephrotic syndrome. In nephrotic syndrome, what is the problem? Let me tell you what is the problem in nephrotic syndrome. In nephrotic syndrome, the kidneys are damaged here also. I agree, the kidneys are damaged here also. The kidneys are damaged that way that there is massive proteinuria. Massive proteinuria. Here most of the protein present in the blood is lost in urine. Most of the protein present in blood is lost in urine. That is the main problem here. Here there is massive proteinuria is main problem. Massive proteinuria is the main problem. Sodium water retention is not main problem. Here massive proteinuria is the main problem. Since massive proteinuria is the main problem, so most of the protein is lost in urine only. So in the blood there is less protein. So in the blood there is hypoalbuminemia. Hypoalbuminemia will be there in the blood, right? Hypoalbuminemia. Now in edema session in pathology, I taught you the pathogenesis of edema. There are two pressure, hydrostatic pressure and osmotic or oncotic pressure. The osmotic and oncotic pressure is due to the protein. Since there is less protein in the blood now, so that's why patient have edema. So the cause of edema is different in both of them. Here the cause of edema is sodium water retention in nephritic syndrome. In nephrotic syndrome, the cause of edema is massive proteinuria or hypoalbuminemia. So please understand these details. You got my point? That is the cause of the edema here. Now let's come on the lipid. Why the lipid is increased in blood as well as in urine. Now here the liver will try to compensate. Here there is massive proteinuria, so liver will try to compensate the protein synthesis. You know, liver synthesizes protein. Most of the protein is lost in the urine, so liver will say, oh my god, I have to compensate now. So liver will try to synthesize the protein, but liver cannot synthesize main protein. It will not synthesize albumin. Liver will synthesize lipoprotein. Lipoprotein is a type of protein. That's why the lipid is increased in the blood as well as in urine. So that's why patient have lipiduria and lipidemia. You got my point? So these are the features of nephrotic syndrome. You got it? Can we go ahead? Can we go ahead? Yes. Yeah, you are right, Krishnan. So here in nephritic syndrome, the problem mainly is not in basement membrane. In nephrotic, main problem will be in the basement membrane. That's why here proteinuria is mild, here proteinuria is severe, you can say. So we should go to the main type of the glomerulonephritis. We will start now one by one. Let's start with the first one, APGN or PSGN. Can I start? APGN, PSGN, acute proliferative glomerulonephritis, also known as post-streptococcal glomerulonephritis. Say yes if you people are there. Can we go ahead? Okay, so let's start with the first one. So APGN and PSGN is one and the same thing. Acute proliferative glomerulonephritis, post-streptococcal glomerulonephritis. Let me draw the etiopathogenesis in front of you in the form of a diagram. Imagine a human being. Okay, let's draw a human being. Imagine a human being. These are the tonsils of this human being, pharynx or tonsils. Okay, this is the kidney of this human being and this is the blood vessel. It's a rough sketch diagram. Imagine this person have tonsillitis or pharyngitis by a bacteria. Which bacteria causes tonsillitis in microbiology? You may have read it, na? The name of the bacteria is group A beta streptococcus bacteria, gas bacteria. So this person have gas tonsillitis or pharyngitis. It's very common. We have tonsillitis multiple times in your life, na? So it is the gas bacteria which causes it. Now, apart from that, the person can have skin infection also, which is also caused by the gas bacteria. After causing tonsillitis or skin infection, the bacteria is coming in the blood. From the blood, the bacteria is going in the kidney. The bacteria are going in the kidney. In the kidney, we have nephron. Each kidney have 1 million nephron. Inside the nephron, we have filtration barrier. Let me draw filtration barrier here. Kidney may have filtration barrier. So let me draw the filtration barrier here. So this is the filtration barrier I am drawing. So this is the basement membrane. On one side, we have endothelium. And on one side, we have visceral epithelium or podocyte. So inside the kidney, so where is the bacteria getting deposited out of the three? In the filtration barrier, we have three options. So the bacteria getting deposited over the podocyte. So can we call this bacteria as planted antigen? Yes. So this gas bacteria become the planted antigen now. It is the planted antigen. So imagine the person is having tonsillitis, skin infection. The bacteria is going in the blood. From the blood, it is going to the kidney. From the kidney, it is going to the filtration barrier. In the filtration barrier, it is going to the podocyte, getting deposited here, settled there, done. The bacteria is gone from the blood. Now the body is forming antibody. Antibody is also going pitchy behind the bacteria, and it is also getting deposited over the podocyte. So antigen antibody complexes are formed over the podocyte, right? The podocyte is destroyed, है ना? The complete filtration barrier is destroyed because of the destruction of the podocyte. It become leaky. Now you tell me here, and that's why the person have nephritic syndrome here, not nephrotic. This person will present as nephritic syndrome. Okay, and you tell me what is the mechanism where the antigen antibody complexes are formed. You will say, ma'am, antigen antibody complexes are formed in blood. No, they are formed in the kidney, in the podocyte. So they are in situ formation against a planted antigen. This is the mechanism. So don't say the complete story, say one word. In PSGN, there is in situ formation of antigen antibody complexes against a planted antigen. The planted antigen is a bacteria. It should be in your understanding. You got it? And where are the deposits formed? The deposits have four locations. Is it intramembranous? No. It is subendothelial? No. It is mesangial? No. It is subepithelial because they are formed on the podocyte. Podocyte is epithelium. That's why the deposits are subepithelial out of the four locations. Say yes. Okay. Okay, so this is the thing. So tell me, so if you have this diagram in your mind, you can read this flow chart. Please, can you say it with me? Group A beta hemolytic streptococcus, that is gas bacteria is there. The gas bacteria is causing pharyngitis or skin infection, right? From there it is coming in the blood. From there it is coming in the blood. From blood it is going to the kidney. In the kidney it is going in the filtration barrier. In the filtration barrier there are three options: the basement membrane, the endothelial cell on one side, and podocytes on other side. So it is going to the podocyte. It is known as planted antigen. Now behind antibodies are also going, है ना? And I've used the word piche intentionally, behind. You should have an intention that the antigen antibody complexes are not formed in the circulation. First bacteria is going, deposited there and eliminated from the blood, and behind antibodies are coming and deposited there. So I want to insist the word in situ formation of antigen antibody complexes against a planted antigen, and here the deposits are subepithelial. Okay, got it. See this diagram, you can understand it. I guess the diagram is from Robbins, and I guess the credit should go to Robbins. And you can see, can you see here the podocytes? Appreciate these podocytes. Can you see the red dot on the podocyte? The red dot is the planted antigen, that is the bacteria. Can you see the black color antibodies? Let me highlight. These are the antibodies formed in the blood, and piche these antibodies are also coming. Antigen antibody complexes are formed subepithelial. You got it. Thank you for the compliment, Sami. Thank you so much. Okay, can we go ahead? Everyone give me a thumbs up. What is the gross of this kidney? It's flea bitten kidney. What is flea? And why it is biting? Flea is an insect like the mosquito. Have you seen mosquito? Have you had mosquito bite ever in your life? I guess everyone have. So whenever mosquito bite us, there are small hemorrhagic dots at that place. So it is looking like the flea have bitten the kidney at multiple places. Can you see? Flea as an insect, so it is biting the kidney at multiple places. It's just a proverb to say. It is actually not flea is coming and biting the kidney. No. The kidney is looking like the flea have bitten the kidney at multiple places because of the multiple hemorrhagic spots. These are multiple hemorrhagic spots on the entire kidney. It's a very important PYQ in your exam, and it's a very important image-based question. It's a spotter. If this image is coming, it should be clear to you. It's a flea-bitten kidney, typically seen in PSGN or APGN. Okay, so learn this word in the gross. And why these are multiple hemorrhagic spots? Come on, because of the podocyte, destruction of the podocytes at multiple places. That destruction is by antigen antibody complexes. Now coming on the three type of microscopy. Are you people there? Keep interacting with me. Come on. So let's come on the three type of microscopy. Light microscopy, the first, the second is electron microscopy, and third is immunofluorescence. So light microscopy, this is the diagram. Can you see? This is the glomerulus. In this diagram, one glomerulus in the center shown to you. Let me highlight the glomerulus. This is the glomerulus. You will see, ma'am, inside the glomerulus, you told us multiple capillaries are there, and each capillary have three filtration barrier, the three components of the filtration barrier. So yes, I told you this. So I can see this is illuminated capillary, this is a capillary, this is a capillary. I can see multiple capillaries. I hope you too can see multiple capillaries. These all are capillaries, you can see. Now you will say, ma'am, okay, we can see the capillaries. Where is the endothelial lining? You can see the flattened cell. Try to appreciate, zoom out and try to see these flattened cells. The flattened cells on inner side is endothelium. The red color I have drawn is the basement membrane. You will see, ma'am, outer to this, there should be only one layer of the visceral podocyte. Why I can see multiple cells? Because outer to this podocytes are there, but apart from podocytes, multiple inflammatory cells are there. Most of these cells are neutrophils. See, these are multilobated, and some of them are lymphocytes. These are lymphocytes. So basically inflammatory cells, the neutrophil and lymphocytes are coming inside the glomerulus and causing the inflammation. That's why the size of the glomerulus increases. Say yes or no? Yes, the size increases, right? The cellularity is increased. Normally only 3 layers are there. I can see multiple layers of multiple inflammatory cells. Cellularity is increased. Cellularity means proliferation. So the proliferation is increased. Yes, so this is the only finding in APGN. That's why it is known as acute proliferative. Now you can understand the meaning of the term acute proliferative glomerulonephritis. It is proliferative. Proliferative means cellularity is increased. It is known as post-streptococcal because it is occurring after the streptococcus infection. You can understand the both terms. You got it? So what I will say, the glomerulus increases in size, increases in cellularity, increases in proliferation because of the WBCs. That is the only finding. See the size. It is increased in size, increase in cellularity, increase in proliferation. That's it. Done. See the normal glomerulus, this one, and see the glomerulus in APGN. You can appreciate what 3 things I am asking you to look for. Let me highlight. Give me a minute. Let me highlight. Okay. See the normal glomerulus. This is normal. And see the glomerulus in APGN or PSGN. See what you can see. You will say, ma'am, size is more, cellularity is more, proliferation is more. Say, give me 3 thumbs up. Size is more. Can you see? Cellularity is more. Can you see? Most of the cells are lymphocytes here, lymphocytes and neutrophils, inflammatory cells I mean, and the proliferation is more. So that is the only finding in APGN. We are done with light microscopy. Let's come on electron microscopy. What you will see in electron microscopy? I told you, you see the location of deposit. I already told you it's subepithelial. There are 4 locations. I will say last time, I will not repeat the 4 locations again, right? See, in the center there is a basement membrane. On one side there is endothelium, on other side there is visceral podocytes or epithelium, and apart from that we have supporting cells that is known as mesangium all around. This is all mesangial cells. Now we have 4 locations. What are the 4 locations? Number 1, the deposits can be on the basement membrane, that is epimembranous deposits. The deposits can be on the endothelium. These are known as subendothelial deposits, and the deposits can be on epithelium, okay, visceral podocytes. These are known as subepithelial deposits, and the deposits can be on the mesangium. These are known as mesangial deposits. So these are the 4 variants of the deposits, right? By deposit I mean antigen antibody complex. So tell me, in this case, PSGN, where the deposits are formed, where the antigen was planted, bacteria was planted over the podocytes. That's why the deposits are subepithelial. Say yes. So the deposits are subepithelial. In this diagram, you can see the pink color are shown the deposits. Can you see the pink color, the pink highlight? They are just below the epithelium. They are on the visceral podocytes. These are subepithelial, right? Now you can see the electron microscopy. This is one of the deposit. Can you see? The deposits are big, right? The deposits are like, have you seen a camel? Have you ever seen a camel? At least a diagram of a camel. Let me try to draw. I'm poor at drawing, but I will try. I want to show you the hump of a camel. This is known as hump of a camel. You have seen camel have a hump, okay? So the deposits are looking like that. Can you see? It is known as humpy deposits. From here the word humpy is derived. Hump of a camel, humpy. It is big in size. That's why known as lumpy, or it is known as bumpy. Lumpy, bumpy, humpy deposit. Say yes. So what is the name of this deposit? Lumpy, bumpy, humpy. Lumpy, bumpy, humpy deposit. So never forget, it is a clue for your question, right? And coming on the last and the third microscopy, immunofluorescent microscopy. Okay, in immunofluorescent microscopy you come to know the composition of deposit, not the location. Location is seen in electron microscopy. In immunofluorescence we see the composition of the deposit. Okay, in the composition we have an antigen, we have an antibody. You will say, ma'am, complex kya hai? Complex mein there is one antigen, one antibody. So what is the antigen? You will say, ma'am, antigen is gas bacteria. You told us. Yes. What is the antibody? Which antibody? Now we have 5 options of the antibody. Now IgG, IgA, IgM, IgD, IgE. So here always IgG will be there. Always, in all type of glomerulonephritis, all 9. Out of all 9, 8 of them have IgG antibody in the complex except one, that is IgA nephropathy. IgA nephropathy का नाम ही IgA nephropathy इसलिए कि उसमें complex में IgG की जगह IG है. Remaining 8 have IgG. Okay, and apart from that there is a complement. So there is an antigen, there is an antibody, there is a complement. There are 9 complement now, C1 to C9, C3 will come here. So see, I have drawn a deposit for you. In the deposit, we have one antigen, we have one antibody, and we have one complement. Okay, can you name the antigen? Yes, you should name it, ma'am, gas bacteria. Can you name the antibody? Yes, you should say, ma'am, it's IgG antibody. Can you name the complement? You should say, ma'am, it's C3 complement. This is the composition that we can see on immunofluorescent microscopy. Say yes. So in immunofluorescent microscopy, the IgG and C3 is there. IgG and C3. Antigen to jo hai, antibody and complement I am interested. Okay, that is immunofluorescence. So the 3 type of microscopy summary in front of you. I am done with the first type of glomerulonephritis, PSGN. Everyone give me a thumbs up. Got it? Light microscopy, electron microscopy, immunofluorescent microscopy. Light microscopy, tell me 3 findings. Increased size, increased cellularity, increased proliferation. Instead of learning, try to see in the diagram, appreciate in the diagram. Done. Electron microscopy, tell me the location of the deposit. Say one word, subepithelial. Lumpy, bumpy, humpy, dumpy deposit. Okay? So you can see. Instead of learning, try to see in the diagram. Right? Immunofluorescence, say the composition of the deposit. Say, ma'am, it's IgG plus C3. Antigen के साथ one antibody and one complement, right? It is seen like this, right? It is fluorescent. Okay, so with the help of this we can come to know the composition. So light microscopy, electron microscopy, immunofluorescent microscopy. Clinical feature, it leads to nephritic syndrome, not nephrotic. If I say nephritic, you know what 5 things I am talking about. Just now I told you the nephrotic. So you know, I will not repeat the 5 things. You know what are the 5 clinical features under nephritic syndrome. I am done. We will solve some MCQs and come on the second type of glomerulonephritis. So the way is good, the speed is good. You want me to teach you all 9 glomerulonephritis with this way? Say yes, no. How many of you with me? Can we continue? This is the first glomerulonephritis we have completed. Can we continue the same way? Are you listening me? Come on, respond. Okay. So we will solve few MCQs on this. The first question is in front of you. You have to answer in the chat box. All are true about post-streptococcal glomerulonephritis except, tell me what is the exception. Is it crescent formation seen? Yes or no? Epithelial deposit, subepithelial deposit? Yes or no? Granular deposits of IgG? Yes or no? And deposition of IgA? Yes or no? Okay. What is the correct answer? Okay, you all are right. The correct answer is D, because IgA never occurs in the deposit except in IgA nephropathy. IgG occurs, subepithelial deposits occur. Crescent why occur? I will tell you. Some of them you may be confused कि मैम crescent तो आपने बताया नहीं. I will tell you crescent about it. Rarely in PSG and crescent also formed. Okay, so I will tell you how. Correct answer is D. Subepithelial deposits are characteristic of which glomerulonephritis? Is it minimal change disease, membranous glomerulonephritis, membranoproliferative glomerulonephritis, or post-streptococcal? Currently, I taught you only one, and you know the answer. It's post-streptococcal only. Everyone will say the same answer. I know, but you know the deposits in other three. In minimal change, there is no deposit. In membranous, it's epimembranous deposits. In membranoproliferative, it's subendothelial deposits. Right? Here epimembranous, so subepithelial occurs only in this. So this question will be much better if I give you this question after teaching all 9 glomerulonephritis, then you will get confused. Okay, anyways, come on the next type. The pathogenesis of acute proliferative glomerulonephritis is what? Why acute proliferative glomerulonephritis happens? Is it cytotoxic T cell mediated injury? Is it immune complex mediated injury? Is it antibody mediated injury? Or is it cell mediated injury? What you will say? Who will say it correctly? Let me tell you. Yes, what is the correct answer? I'm waiting. Please be fast now in your answers. Yes, you all are right. The correct answer is B. It is the immune complex which is destroying the podocyte and leading the disease. It is not the cell, not the antibody, not the type 4 hypersensitivity. It is the antibody. It is in situ formation of antibodies, antigen complexes against a planted antigen. So we are done with APGN. Let's start RPGN. Let's start the second type of glomerulonephritis, that is RPGN, rapidly progressive glomerulonephritis. Let's start it. So there are 3 types of RPGN. The 3 types of RPGN is type 1, type 2 and type 3. The 3 types of RPGN, type 1, 2 and 3. Okay, so let me explain you the pathogenesis of all 3 in detail one by one. Now we have to see the pathogenesis of all 3 separately, but the light microscopy, electron microscopy, immunofluorescence will be in common. Okay, so let me tell you the pathogenesis separately. Let's start type 1. Type 1 is also known as good pasture syndrome. Very, very important, ultra important. So what is happening now here? The body is forming antibodies, autoantibodies against the collagen. So as I told you, there is a basement membrane in the center. On one side there is endothelium and on one side there is visceral epithelium. So basement membrane is made up of what? The basement membrane is made up of collagen. It is known as type 4 collagen. You may be knowing the basement membrane is made up of type 4 collagen. So basically the body will form autoantibodies against the own cell. The collagen is the own component now, but the body is forming antibodies. These are known as autoantibodies. So these autoantibodies will come and bind here and form antigen antibody complexes. So you tell me the location where the antigen antibody complexes are formed in type 1 RPGN. The antigen antibody complexes are formed in the epimembranous. It is not subepithelial, subendothelial. It is epimembranous. Number 1, they are formed in the membrane itself. That is epimembranous deposition of antigen antibody complexes, right? And it is an autoimmune disease. Here, the antigen antibody complexes are formed in C2. They are not formed in blood because antigen is not present in the blood. Antigen is present in the kidney, so deposits are formed in C2 against a fixed antigen. Here, the antigen is fixed. It is not planted. It is fixed there, right? So, and epimembranous deposits are there. You got my point? So, this is type 1. And the same basement membrane type 4 collagen, it is present in the lung. This one is kidney. This is present in kidney. This one, the basement membrane here, the filtration barrier is present in kidney. But in the lungs also, this is a diagram of the lungs I am drawing. In the lungs also, same type 4 collagen basement membrane is present. Alveolar basement membrane, right? It is also having type 4 collagen. So the antibodies which are formed against the kidney, they will cross react with the lung basement membrane also. So 2 organs are involved in type 1 RPGN, that is good pasture syndrome. The type 1 RPGN is known as good pasture syndrome because it is discovered by the person good pasture. Here 2 organs are involved, I repeat, the kidney and the lung. The reason for both of them is autoantibodies which are formed against type 4 collagen. So type 4 collagen is present in the basement membrane of the kidney as well as the lung. So you will get a typical question that there is a middle-aged person, male, female, whatever, having 2 complaints. Number 1, hematuria. Hematuria is indicating nephritic syndrome like the kidney problems, and number 2, pulmonary hemorrhages, sputum, coughing and pulmonary hemorrhages. So 2 organs are involved, the kidney and the lung. The answer is straightforward. It's type 1 RPGN or good pasture, whatever you say. Say yes if you got it. Everyone got it? So what is type 1 RPGN? It is also known as anti-glomerular basement membrane disease because the body is forming antibodies against the glomerular basement membrane. It is also known as Goodpasture syndrome. You got it? Huh? Say you got it or didn't got it? So the antigen, who is the antigen? Type 4 collagen present in the basement membrane. The body is forming antibodies against that. The antibodies are forming immune complexes against the basement membrane and in situ deposition against a fixed antigen. The fixed antigen is the type 4 collagen. That's why patients have renal failure, nephritic syndrome, and they will go in the lung and cross-react with the lung alveolar basement membrane causing pulmonary hemorrhages. The patient have two problems here, right? Who is the antigen? Type 4 collagen. And who's the antibody? The autoantibody. So the deposits are formed. Let me come on type 2. Type 2 RPGN. Type 2, I will not explain you type 2 because type 2 is exactly same as that of PSGN. I have already explained you PSGN now. So in PSGN, I told you in a subset of PSGN, the crescent will form. That is type 2 RPGN. So type 2 RPGN is PSGN. Here also the same story. The bacteria cause tonsillitis. The bacteria will go in the blood. From the blood it will go in the kidney. In the kidney it will go the filtration barrier. In the filtration barrier it will go to the podocyte. Get deposited there. So here we have a planted antigen. And antigen antibody complexes will be formed again in situ but against a planted antigen. That is type 2. Okay, that is type 2, that is post PSGN, the same story. Coming on type 3. In type 3 antibodies are not formed. In type 3, actually it is the CD8 T lymphocyte, you know, the cellular one. Antibody mediated nahi hai ye. CD8 T lymphocyte will go and destroy the filtration barrier. It is cell mediated. That's why it's known as POSI immune. POSI ka matlab hota hai less immune. Less immune means here antibodies are not formed. Here antibodies are not formed, right? So let me draw the 3 type of RPGN in front of you in short. RPGN is of 3 type. Type 1, type 2 and type 3. टाइप 1 का बेस्ट एग्जांपल है गुड पास्चर सिंड्रोम, टाइप 2 का बेस्ट एग्जांपल है पीएसजीएन और एपीजीएन और टाइप 3 का बेस्ट एग्जांपल है वेगनर ग्लोमेरुलोनेफ्राइटिस. फर्स्ट लर्न द एग्जांपल्स ऑफ ईच ऑफ देम प्लीज. गॉट इट? नाउ आई वुड लाइक टू ड्रॉ द 3 filtration barriers in front of you quickly to explain you the pathogenesis of all 3. I will quickly draw it. Your concept should be crystal clear. You got it? Renal system is something what now most of the students have very trouble in understanding the concepts. Listen. The 3 basement membranes are in front of you. I mean the filtration barrier in front of you. Now tell me what is the problem in type 1. You will tell me. What is the problem in type 1? Who is the antigen? Who is the antibody? Is it antibody mediated? Yes. This one is antibody mediated. This one is also antibody mediated. Here who is the antigen? You people don't interact. Come on, say na. So who is the antigen? The antigen is type 4 collagen. It's an autoimmune disease. Here the antigen is type 4 collagen. The antigen is a fixed antigen. It's type 4 collagen. So the body is forming antibodies against the fixed antigen. That is type 4 collagen, and antibody antigen complexes are formed in situ inside the kidney only. That is type 1. Here not only kidney, the lung is also involved because of cross reaction I told you. Coming on type 2 RPGN. Who is the antigen here? The antigen is a bacteria which get deposited over the podocyte. The antigen is a bacteria which get deposited over the podocyte, right? It is gas bacteria. So the antigen is a planted antigen. Right, and here also the antibodies will come and bind behind the bacteria. Antigen antibody complexes are formed in situ. It's like same PSGN. Okay, in type 3 it's not antibody mediated. Here the CD4 and CD8 lymphocyte will come and destroy the barrier, the lymphocytes. It's known as POSI immune. It's known as POSI immune. You got it? You got it? Can we go ahead? Say yes. I will come on the crescent, Ambu. Wait a while. Let me explain the pathogenesis. Right, here one more thing. Tell me the complexes, the location of the complexes in all 3. Who will tell me the location of the complexes in all 3? So here in the first one, you can see the complexes are formed inside the membrane. These are known as epimembranous or intramembranous. In the second, type 2, you can see the complexes are formed over the podocytes. That is epithelium. That is known as subepithelial deposits. Here the deposits are epimembranous. Here the deposits are subepithelial. In type 3, so antigen antibody complex hai nahi. There is no. So here complexes are absent. Nil, no complexes. That's why known as POSI immune. Say yes if you got it. One more thing, the last thing I would like to highlight in 1, 2, 3 is that, how should I explain? Here the deposits which are formed, they are epimembranous and they are linear. And here deposits are subepithelial and they are granular. So two differences are there. You will say, ma'am, epimembranous and subepithelial, we got it. The reason here epimembranous because the antigen is the type 4 collagen, and here subepithelial because the bacteria get deposited on the podocyte. That is the thing. But why linear and granular? What is the reason for that? Can anyone give a guess? Can anyone give a guess? What is the meaning of the linear and the granular? What is linear? Linear means, you know, the basement membrane have the collagen at a same distance. Now, so this is type 4 collagen again at a particular distance. This is type 4 collagen. It is uniform distribution, I mean, the type 4 collagen. So antigen antibody complexes are very uniform, they are linear. है ना, जहां जहां एंटीजन वहां वहां एंटीबॉडी, wherever antigen there antibody will come, and complex will be very uniform, very uniformly neatly placed, है ना. That is type 1. But in type 2, bacteria will deposit anywhere. It is not a fixed pattern. On this podocyte bacteria are more, on this podocyte the bacteria are less. It is a planted antigen, it's not a fixed antigen. So basically antigen antibody on some podocytes it will be more, on antigen antibody complexes on some it will be less. So it is slightly granular. So say if you got the meaning of the linear and granular, now you will never forget, right? So please learn the highlights. Let me highlight the 3: type 1, type 2, type 3, the 3 type of RPG, and learn their examples. Goodpasture syndrome is type 1, PSGN is type 2, and Wegener glomerulonephritis is type 3. One more thing you have to learn is their deposits. If you understood the pathogenesis, it's good. If you didn't understand, learn their deposits. In type 1, the deposits are epimembranous and linear. In type 2, the deposits are subepithelial and granular. In type 3, the deposits are nil. Okay, and learn their mechanism. In type 1, the mechanism is fixed antigen, in situ antigen antibody formation. In type 2, it is planted antigen, which is a bacteria, gas bacteria, and again it's in situ, it's not circulating. In type 3, it is cell mediated, known as posse-immune, where CD4, CD8 lymphocytes are destroying the basement membrane. I tried my best. Can we go ahead? Can we go ahead? Are you people there? Okay. So that is the 3 thing. Now light microscopy of all 3 is same. I will not teach you type 1, type 2, type 3. The light microscopy of all 3 is same. The highlight here is the crescent formation. The crescent formation is the main highlight here. Can you see here? Please see the kidney. Please see the glomerulus. Have a look on the glomerulus. This is the glomerulus. Can you see the glomerulus? Okay. In the glomerulus, what you can see? Okay. Tell me what 3 things you see in the glomerulus of PSGN. You will say, ma'am, size is more, cellularity is more, proliferation is more. So same thing here also. See this portion of the glomerulus. Can you see the size is more, the cellularity is more, the proliferation is more. But apart from that, one additional feature is this. Something is formed like this. Can you see I'm highlighting? What is the shape of this thing? Inside the glomerulus, a crescent, sickle shaped something is formed. This is known as crescent. Crescent matlab it is a sickle shaped thing which is formed in the glomerulus, compressing the glomerulus and making it inactive. This crescent is formed. So crescent is made up of the epithelium, the Bowman's capsule epithelium, that is parietal epithelium and lymphocytes. Parietal epithelium and lymphocyte, a crescent is the hallmark. So the 3 things. So let me compare PSGN and all 3 type of RPGN. Okay, PSGN and all 3. So let me compare the light microscopy of both of them. So here on light microscopy, we have increased size, increased cellularity, increased proliferation. Here in light microscopy also, we have increased size, increased cellularity, increased proliferation, along with only one difference, the crescent. So I mean to say crescent is the only thing which differentiate the 2 type of glomerulonephritis. Say yes. Okay, can we go ahead? Coming on the electron microscopy, I already told you, no need to say. In type 1, the deposits are epimembranous and linear. In type 2, the deposits are subepithelial and they are granular. And in type 3, there are no deposits, that is, they are nil. Okay, immunofluorescence composition is always same. It's IgG plus C3. It's IgG plus C3. Here, no deposits are there. Right? Please appreciate the 2 immunofluorescence diagram. Can you see the first diagram? This one. Here you can see a little bit linearity. And please see the second. It's little bit granularity. So this is type 1 and this is type 2. Appreciate everyone. Can we go ahead? So this is the summary of the RPGN in front of you. In light microscopy, it's crescent formation. In electron microscopy, you see the location of the deposits. And in immunofluorescence, you see the composition. This one is linear, this one is granular, and both of them are made up of IgG plus C3. I am done with RPGN also. It also presents as nephritic syndrome. Like PSGN also, it's the same nephritic. So this one is also nephritic, this one is also nephritic. Okay, so please say the etiopathogenesis of both of them. Here gross may I told you flea bitten kidney. Here gross is not important. Light microscopy of both of them, electron microscopy of both of them, tell the location of the deposit and immunofluorescence of both of them. Can we go on the third one, MCD? How many of you with me? Can we go ahead? Before that, we will solve some MCQs on RPGN. The first question is in front of you. Very easy question. On RPGN, the question will always be on crescent. Crescent is the hallmark feature. So crescent formation is a characteristic feature of which glomerulonephritis? What is the correct answer? Is it minimal change disease, RPGN, focal segmental glomerulonephritis, rapidly non-progressive glomerulonephritis? I guess question is super simple. Kuldeep is first to answer. Paras, yes, you are absolutely right. What about others? I want everyone to participate here. Come on. At max, you will be wrong. Okay, good Osama. Good try. Yes. Yes, very good, very good, very good. You all, Aisha, you all are right. So correct answer here is B. It's RPGN. Okay, coming on the next question. Crescents are made up of what? What is the composition of the crescent? I forgot to tell you, let me tell you, the crescents are made up of epithelial cells of the Bowman's capsule, the visceral and parietal epithelial cells. Along with that, it contains the macrophages, that is WBC, and it contains fibrin. So this is the composition of the crescent. Please learn it. Okay, one more question, very, very important, repeatedly asked PYQ in front of you. There is a patient present with hemoptysis and renal failure. See, the two organs involved. What is hemoptysis? Hemoptysis का मतलब क्या होता है? It is blood in sputum. Blood in sputum. Sputum. Why the patient will have blood in sputum? The patient may have pulmonary hemorrhage, so the lung is involved. Okay, number one. And number two, renal failure. The kidneys are also involved. So tell me a disease in which the two things are involved, the lung and the kidney. And one more clue to you is anti-basement membrane antibodies are there. Anti-basement membrane antibodies are there. Is it Goodpasture, Wegener, Church-Strauss or HS purpura? So what is the correct answer? You all are right. Super, super. The correct answer is Goodpasture, but it is a repeatedly asked PYQ. The language may be different, but conclusion is same. Two organs will be involved with the autoantibodies in the blood. So that is the thing. One more thing, linear deposits along the basement membrane is seen in. Linear deposit is one clue, and along the glomerular basement membrane, anti-GBM, it is seen in what? Goodpasture syndrome, SLE, drug reaction or HS purpura? You tell me the answer. Again, the answer is A. Yeah. So they are talking about type 1 RPGN. Type 1 RPGN, the deposits are linear. They are against the basement membrane. Okay. And it is Goodpasture syndrome. So coming on the next one, MCD, minimal change disease. Okay. We are done with PSGN. We are done with RPGN. Now I'm coming on MCD, minimal change disease. It is a disease of children. It occurs in children. It occurs in children. Why it is known as minimal change? Because I told you three type of microscopy, no? Light microscopy, electron microscopy, immunofluorescent microscopy. So here in light microscopy, you see nothing. The light microscopy is absolutely normal and you miss the disease on biopsy, right? You can, and immunofluorescence is also normal. You can see change only on electron microscopy. So electron microscopy is the hallmark here. Right, that's why it is known as minimal change. Minimal yani hardly you see any change on light microscopy. That is a meaning. Everything have a meaning behind that. If you know that meaning, you will not forget that thing. So minimal change disease have no change on light microscopy. So you will miss the disease on biopsy. Right, that's why minimal change disease. It occurs in children and it causes nephrotic syndrome, not nephritic. Okay, the first two were leading to nephritic. This one is nephrotic. Right, this is the most common cause of nephrotic in children. It occurs in children. What is the pathogenesis? It is not antibody mediated. Antibody hai nahi, neither in situ, nor circulating, not fixed, not planted, nothing. It is cell mediated. The CD4, CD8 lymphocytes are coming and destroying the basement membrane. So it's again post-immune like type 3 RPGN. है ना? So it's post-immune, so no deposit. यहाँ पे nil deposit like type 3 RPGN, nil deposit. So here is the basement membrane. Here is the endothelium. Here is the epithelium or visceral podocyte. I am talking about MCD. I am talking about MCD, minimal change disease. So what is causing? So in all glomerulonephritis, you have to destroy this filtration barrier. That's why you have to draw it again and again. So who's causing the destruction? Is it antibody? No. It is not antibody. Who's causing? The cell mediated. The cells CD4 and CD8 lymphocytes are coming and they are destroying. They are destroying it. So it is cell mediated. So no deposits, nil deposits. That's why it is also known as nil deposit disease. Nil. So two names you should understand: minimal change disease because light microscopy is normal, and nil deposit disease because no deposits are there. You got it? Can we go ahead? Grossly kidney is normal. Light microscopy, it's normal. Normal होना ही अपने आप में abnormality है. The patient will present to you. Patient will be a child. Imagine the parents. You are a pediatrician and the parents are coming to you. Doctor, my child is edematous. Come on, see the face. It's puffy. You know, I'm having. So the child will be 3-year, 5-year-old. There can be a girl. There can be a boy. Parents will carry to you. Doctor, my child have severe edema. So whenever the child will have severe edema, you will do urine analysis. In the urine analysis, you come to know, oh my God, there is massive proteinuria. Most of the protein is lost in the urine. You will do a blood protein concentration, you will see. So it is hypoalbuminemia. In the urine, there is protein. In the blood, there is less protein. And along with edema, you will say it's a typical case of nephrotic syndrome. You will order immediately a biopsy. The biopsy is absolutely normal. Light microscopy is absolutely normal. So a child with a nephrotic syndrome with normal biopsy is MCD. So here, absolutely normal. You can see absolutely normal glomerulus. No increase in size, no increase in cellularity, no increase in proliferation, no crescent, nothing. It's normal. Normal hona apne aap mein highlight hai. You got my point? On electron microscopy, so in such case, what should you do? Being a doctor, you cannot treat the patient directly. Now, based on clinical symptom, we can start the treatment. But if you want to become sure and confirm the diagnosis, you should order electron microscopy in such case. Because being a doctor, you should know, I mean, being a specialist in that, you should know that it is a case of MCD you are suspecting, and in MCD the light microscopy is normal. So you should directly order electron microscopy, right? In electron microscopy, what you see? Normally we see the location of the deposit. आप बोलोगे मैम deposit तो है ही नहीं ना? There is no deposit. So why location of deposit? In electron microscopy, we don't see here the location of the deposit because deposits are absent. See what I am drawing. I am drawing two filtration barriers in front of you. Let me draw the basement membrane. Okay. Let me draw the endothelium. Okay, let me draw the podocyte. Now here is a catch. See, normal shape of the podocyte. This is normal healthy kidney. The podocytes are like this. And the podocytes are foot shape. The podocytes are foot shape. This is normal filtration barrier. In MCD, they become flattened. I use the word flattening. Appreciate the change. I want you to appreciate this. Right? This is known as flattening of podocytes. Okay, either you say flattening of podocytes, either you say attenuation of podocyte, whatever word you use, this is the hallmark here. Yes, drug of choice will be steroid. I'm coming on that. Say yes if you got it. So please appreciate the normal kidney versus MCD, that is minimal change disease. So that is you can see on electron microscopy, not on light microscopy. The light microscopy is normal. So in electron microscopy, we are not seeing the deposit because deposits are not formed. So milega kaise? There is no antibody mediated pathology now. Here the cells are destroying. It is cell mediated. CD4, CD8 lymphocytes are destroying. So it is electron microscopy. You don't see deposit. You see flattening of the food processes or effacement of the food processes. You got it? And on immunofluorescence also nil deposit, no deposit. So out of the three microscopy, light microscopy is normal, immunofluorescence is also normal. Only abnormality you can see on electron microscopy, that is obliteration or loss or fusion or effacement, whatever you say of food processes. The meaning is same, the food processes become flattened. Either you say the word fusion, you say the word loss, you say flattening, you say attenuation, you say obliteration, kuch bhi bol lo. The meaning is same. And it leads to nephrotic syndrome. Drug of choice, prognosis is good. Drug of choice is steroid. You give a single dose of steroid, the child will be good. Okay, so that is a thing. So till now we done APGN, we done RPGN, we done minimal change disease. Say yes, everyone. I want to compare the three in short, and then I come to the next two together. These two I will take together. Okay, so soon we will finish. Now the rest of them are not very important, so we will take them quickly in short. Okay, so APGN, what is the etiology? Who will help me in writing here? Anyone from the audience? Let's talk about APGN. APGN, what is the etiology? You say, is it in situ or circulating antibody complex formation? Which one? Yes, it's in situ. In situ complex formation against a planted antigen or a fixed antigen. So yes, it's planted antigen. The antigen is the bacteria. I'm not repeating the whole sequence. Imagine the diagram I had drawn. Right, so the bacteria, tonsillitis causing and how it is causing. In the gross, you say flea bitten kidney. Okay, in the light microscopy, three things will increase. The size will increase, number one. The cellularity will increase, number two. The proliferation will increase, number three. Okay, in electron microscopy, the deposits are there at the subepithelial, which are known as lumpy, bumpy, humpy, dumpy. Please learn these words. In immunofluorescence, the composition is always same. It's IgG plus C3. This is how you have to learn and write down. Right? This is how. Okay, so the comparative table, now you have understood now, so no need to say it again and again, the complete thing. RPGN is of three type 1, type 2, type 3. In type 1 and 2, in both of them, in situ deposition of antigen antibody complexes are there. But in type 1, the antigen is fixed, that is collagen. In type 2, the antigen is planted, that is again the gas bacteria. In type 3, it's not antibody mediated, it's cell mediated, that's why known as post-immune. So this is how in short you have to write. Gross, nothing important here. Light microscopy, again the same three things increase. The size increase, the cellularity increase, the proliferation increase, but along with crescent. The hallmark here is the crescent. Electron microscopy, in type 1, the deposits are intramembranous. In type 2, the deposits are subepithelial. In type 3, there are no deposits. The composition is always same. Okay, coming on the third one, the minimal change disease. Who will tell me the minimal change disease? Here etiology is cell mediated. It's not antibody mediated, it's cell mediated. The cells, the CD4, CD8 lymphocytes are coming and crossing. Gross normal, light microscopy normal, immunofluorescence normal. Only abnormality is electron microscopy. What is the abnormality? You will say flattening. Either you say flattening of food process or fusion of food process or obliteration of food process, attenuation of food process, whatever it is of food process. We are done. This is how you have to summarize in short for your last time revision. Can we go ahead? If you try to mug up directly now, you cannot do so. So coming on the next one, membranous and membranoproliferative together. Are you people there? Can we continue? Membranous and membranoproliferative together. Let me see your chat. Just a second. Let me open again the link. So, okay. So let's solve some MCQs on MCD and let's go ahead. Okay. True about light microscopy in minimal change disease. What I'm asking, light microscopy of MCD. Can you tell me what is the answer? Loss of food process, anti-GBM antibodies, IgA deposits, ki no change. Kuldeep, you got confused, I guess. Yes, okay, you corrected. Thank you. So rest all are right. Okay, the correct answer is no change because I'm asking the light microscopy. On light microscopy, no change thing. But if I change, currently our answer is D. But if I change the question from light microscopy to electron microscopy, would you like to change your answer now? What is the answer in that case? What is the answer in that case? Yes? Who will tell me the answer in that case? Yes, in that case, the answer will become A. Very good. Loss of food processes. You got my point. The next question is a clinical question. Typical clinical scenario is given to you. There is a 10-year-old child. Age is always an important clue. Take the clue. So there is something happening in the child. Presented to you with edema. Imagine a child is coming to you in your clinic with the parents having severe edema. You have done a urine analysis. The decreased urine output is there. Oliguria is there. On examination, serum albumin is 2.5. What is the normal concentration? It should be more than 3 gram. The serum albumin. It's hypoalbuminemia. Creatinine is within normal range till now. Urine protein is 3+. In the urine, there is no RBC in the urine. So it is not nephritic, it is nephrotic. The examiner, the author have given you no RBC intentionally. No RBC मतलब patient को hematuria नहीं है. Hematuria नहीं है तो nephritic नहीं है. Nephritic नहीं है तो it is nephrotic. It is a typical case of nephrotic syndrome in a child. So what is the most common cause of nephrotic syndrome in a child? Is it interstitial nephritis, MCD, IgA nephropathy and membranous nephropathy? Among the option, only this one causes nephrotic syndrome. Rest all causes nephritic. So based on that, my answer is MCD. You all are right. You all are right. Can we go ahead? Yes. Very good. So next, the two together I'm going to teach you is membranous glomerulonephritis and membranoproliferative glomerulonephritis. Now उनके नाम में ही उनका meaning है. The meaning is hidden in their names only. See, membranous मतलब here the glomerular basement membrane will get thickened. That's why it is known as membranous glomerulonephritis. I will show you the diagram also. Here membranoproliferative. यहाँ पे दो चीजें हैं. So here also GBM will get thickened. The one thing is common. Here also GBM is thickened because here also membranous, here also membranous. But along with the membranous, it's proliferative also. It's proliferative also means here cellularity will also increase. So here only GBM will get thick. Here GBM will get thick along with the cellularity also. So this one is membranous glomerulonephritis. This one is membranoproliferative glomerulonephritis. Say yes if you got it. So don't go, the pathology is a very simple subject. If you understand the meaning of the words, pathology is not a subject yet. It's a language. If you can understand, interpret the meaning of the words now, you can understand the subject well. You got my point. So the name itself is giving you the meaning. Membranous glomerulonephritis, membranoproliferative glomerulonephritis. You got my point. So this one is membranous glomerulonephritis. It is known as epimembranous nephropathy. Epimembranous nephropathy, it is the most common cause of nephrotic syndrome in adults. So let me tell you the membranous one. First I will teach you the membranous, then I will come on membranoproliferative. In the membranous, what is the problem? What is the problem? The problem is that this is the filtration barrier, the basement membrane, the endothelium and the visceral podocyte or epithelium. Here the visceral podocyte or epithelium have a protein inside it. This protein is known as glycoprotein 330. It is present inside it. It is normal. It is present in me, you, everyone. It is normal. It is a component of this podocyte. Glycoprotein 330, GP330, right? Like the basement membrane have collagen inside that now. In the same way, this is having GP330. And again, an autoimmune disease is there. The body is forming antibodies against that. It is an autoimmune disease. It's a own protein, body own protein. Sometimes body start forming antibodies against this GP330. So you tell me what will happen. You only tell me what will happen. So here the antigen antibody complexes, where they are formed? They are formed against subepithelial. Subepithelial. You should ask me, ma'am, what is the difference between this and PSGN? In PSGN also the same thing was there. But there the antigen was planted. Here the antigen is fixed. The antigen is already present. The antigen antibody complexes are formed in C2, but the antigen is a fixed antigen here. What is a fixed antigen? It's glycoprotein 330. And here the deposits are formed, which are subepithelial. These are subepithelial also, but they are not lumpy, bumpy, humpy like that. So that is the only difference. And otherwise, and because of this, the complete basement membrane, you will see the filtration barrier will get thickened. So that is the thickening of the basement membrane. It is known as membranous glomerulonephritis. Say yes if you got it. So that is the thing. So we are understanding membranous glomerulonephritis. So here the antigen is the glycoprotein 330, which is present on the podocyte. Antibodies are formed against it, and antigen antibody complexes are formed in situ against a fixed antigen, leading to nephrotic syndrome. The same diagram you can see. You got my point? Say yes if you got it. Okay. So the difference between PSGN, the first I taught you, and membranous glomerulonephritis. Let me draw the difference. Here also in both of them, the problem is in the podocyte. Let me draw the podocytes in both of them. This is also have podocytes. This is also have podocyte. You can understand the diagrams, I guess. Here, the antigen is the bacteria. It is the bacteria, the gas bacteria. So it is a planted antigen, which is coming from outside. Here the antigen is glycoprotein 330, GP330. Okay, it is GP330, which is a fixed antigen, which is already present inside this podocyte. It is an inherited component. So here also antigen antibody complexes are formed in C2, and here also antigen antibody complexes are formed in C2. But this MGN is an autoimmune disease, you can say, right? So deposits in both of them are formed subepithelial. But let me draw the shape of these deposits. Please appreciate the shape. That's why I have drawn this diagram. Here the shape of the deposits is like this. Lumpy, bumpy, humpy. It's like this. I'm filling it. It's like the hump of a camel. It's like the hump of a camel. Here the deposits are spiky. Appreciate the spiky word and appreciate the lumpy, bumpy, humpy word. See, deposits location in both of them is subepithelial, but appreciate the humpy and appreciate the spiky. So that is the difference. Say yes if you got it. No one will tell you such differences. Okay, so that is the thing. So here the deposits, so grossly the kidney is normal. Light microscopy, only one finding is there. You can see. What is the finding? Thickening of the basement membrane. Can you appreciate the basement membrane? Let me show you the basement membrane. So this is the basement membrane. You see it is thickened. Everywhere it is thickened, thickening of the basement membrane. Not only this, you can see the spiky deposits. These are the spiky deposits. Okay, so thickening of the basement membrane, it is known as duplication of the basement membrane. इतनी thick हो गई है कि ऐसा लग रहा है कि duplicated है, but actually it is not duplicated. So it is thickened, it is looking like it is duplicated, but actually it is not duplicated. The deposits are subepithelial and they are spiky. They are spiky in nature. Immunofluorescence is same, they are made up of IgG plus C3. We are done. Clinical feature, it is nephrotic syndrome. Coming on the next one, membranoproliferative glomerulonephritis, right? It is also of three types like RPGN type 1, 2, 3. Don't go in the etiologenesis. Light microscopy mein you find two things. Now compare the two. This is membranous glomerulonephritis. This is membranoproliferative glomerulonephritis. Compare the two. Okay. What you have to compare? Here the basement membrane is thickened. That's it. Okay, here the basement membrane is thickened, here also it is thickened, but along with that you can see the cellularity is also increased. See the cells here, see the cells here. Here cellularity is normal, here cellularity is increased. That's why this one is only membranous, this one is membranoproliferative. The word proliferative means cellularity. Now please appreciate the two things. Say yes if you got it. Can you appreciate the two diagrams back to back in front of you? In one of them only basement membrane is thickened, that is membranous glomerulonephritis. In other, along with thickening of the basement membrane, there is increase in cellularity. Say something. Say something. Got it? So that is the thing. So here you can see this is the glomerulus and the basement membrane is thickened and the cellularity is increased. It is known as splitting of the basement membrane or tram track appearance. The basement membrane is such thickened कि ऐसा लगता है कि रेल की पटरी के जैसा है, tram track appearance. So that is the thing. Okay, so we are done with this also. So we are done with APGN, RPGN, minimal change disease, membranous, membranoproliferative. Say yes. I'm skipping the questions now. I'm skipping the questions now and coming on the next. Can we go ahead? The next two I will teach you together, and these two you can read yourself. These are not very important. These two just I will tell you the differences and move on the renal tumors after that. Okay, so we are done with this topic. So let's come on FSGN and FSGS. The next two glomerulonephritis. FSGN and FSGS. Just a second. The next two together. This one is FSGN, focal segmental glomerulonephritis, and focal segmental glomerulosclerosis. Please understand the difference between glomerulonephritis, glomerulosclerosis. What do you mean by that? Focal segmental का मतलब क्या है? What do you mean by focal and segmental? Okay, see the two diagrams are in front of you now. See, how many glomerulus you can see in the first diagram? I can see two glomerulus. I guess you can also see two glomerulus. How can glomerulus you can see in the second diagram? Again 2. Why author or examiner have shown us two images? I mean two glomerulus in each image. There is an intention behind that. See, out of the 2 diagrams, in the first image, this one is normal glomerulus. See, absolutely normal. But this one is having a disease. This one is having a disease. It is not looking normal. See the second one, second diagram. Here also this glomerulus is looking absolutely normal. Okay, and here this is not normal. It is having some disease. So that is the meaning of the focal. Focal means out of the total glomerulus, some are diseased, some are normal. It is not diffuse. The diffuse is the opposite. In diffuse, all the glomerulus are involved. You know, here in focal, some are involved, some are not involved. So there is an intention why 2 are shown to you. The intention is that one is normal, one is abnormal. Your eyes should pick it up. Got it? Got it? What is segmental? Now see the diseased one. See the diseased one in each of them. See, this is the diseased one here. No? In the diseased one, half is normal, half is abnormal. You can see this portion is normal and this one is abnormal. That is the meaning of segmental. कि भाई diseased भी है तो पूरा glomerulus में disease नहीं है. Half is normal, half is abnormal. See the second one. In the second diagram, see the diseased one. So in the diseased, this one is normal, this one is abnormal. Okay, so that is the meaning of the segmental. So first understand the meaning of the focal and segmental. Very few students can understand कि focal का मतलब क्या है, segmental का क्या है. What is the meaning of focal? Out of the total glomerulus, some are involved, some are not involved. Some are healthy, some are diseased. What is the meaning of the segmental? The diseased glomerulus, half normal, half abnormal. So here we are talking about all glomerulus, out of which some are healthy, some are diseased. Some are normal, some are diseased. Here we are talking about one glomerulus. Half is normal, half is disease. That is the meaning. Say yes, yeah, kindly appreciate my efforts. Got it? So I'm trying to explain you the meaning of the focal segmental. So I mean to say both of these diseases are focal, both of these diseases are segmental, but the disease is different. Here there is glomerulonephritis and here there is glomerulosclerosis. See the disease. What is the disease here? See this disease. And what is the disease here? See this disease. Here the disease is proliferation. You can see increased cellularity. Okay, that is glomerulonephritis. And here you can see the sclerosis. Here you can see the pink color sclerosis. So the disease is sclerosis. So say the meaning focal, focal. Both the diseases are focal. Some glomerulus are involved, some are healthy. Both the diseases are segmental. The involved glomerulus, half is normal, half is healthy. But here there is proliferation and here there is sclerosis. So that is the meaning. I tried, at least I tried. No one will try such hard. So that is the meaning. I hope you got the meaning of the focal segmental glomerulosclerosis and nephritis. So I'm ending the primary glomerulonephritis here only. I guess I taught you most of them. Right, and please fill this table by looking at my session, and I'm moving to the secondary one in the diabetes. IgA nephropathy is important, like only thing is important here in immunofluorescence, in all of them you get the composition of IgG plus C3, here you get IgA plus C3. That is the only difference, right? So that is the only important point you have to, and chronic is not important, you can skip. So let me come on the secondary, give me a minute. Okay. Let me come on the secondary glomerulonephritis, in which I would like to teach you only one glomerulonephritis in the secondary. That is diabetic nephropathy. Can I start? Can I start the secondary glomerulonephritis? Are you people with me? The diabetic nephropathy, very important, ultra important. So there are 3 types of glomerulonephritis: the primary, the secondary, and the hereditary. So we have seen the primary. Now I'm coming on secondary. In the secondary, the list is in front of you. In the secondary, the main disease is not the kidney. The main disease is something else. The kidney is involved secondarily. Like in diabetes, the main disease patient is having is diabetes, and secondarily the kidneys are involved. That is known as diabetic nephropathy. Okay, so let's start diabetic nephropathy. You know what is diabetes? Diabetes mellitus I am talking, not insipidus. Diabetes mellitus, the patient have more glucose in the blood, hyperglycemia. The patient have more glucose. It is of 2 types, type 1 and type 2, but in both of them, the glucose level in the blood is more. It is known as hyperglycemia. You got it? That is the meaning of the hyperglycemia, right? Now, if the hyperglycemia is controlled, it is treated with insulin or oral hypoglycemic drugs, it's good. But in some patient, it is not treated. They remain untreated for years. So more glucose in the blood damage 3 organs in human body. More glucose is not good in the blood. It will cause damage chronically over years, 5-10 years. It will cause damage in 3 organs. Number 1, eye, the retina of the eye. Okay. Number 2, nerves, the peripheral nerves. And number 3, the kidney. Okay, so these are the 3 complications of the diabetes: diabetic retinopathy, diabetic neuropathy, and diabetic nephropathy. Currently I am teaching you this renal system, so I am interested in this diabetic nephropathy, right? But you must be knowing the 3 complications caused by the diabetes. Let's come on diabetic nephropathy. Okay, diabetic nephropathy is one of the complications of diabetes if hyperglycemia is not treated over years chronically. Okay, so diabetic nephropathy, what will happen in the kidney? The kidney will get damaged. How? So in the kidney there is glomerulosclerosis. In the kidney, the glomerulus is involved, the blood vessels is involved, the tubules is involved. Okay, let me explain all in front of you. There are two types of glomerulonephrosis in front of you. Please see what are the two types of glomerulonephrosis. One is diffuse, one is nodular. Ultra important topic. Please everyone concentrate. It's difficult, but I will make it super simple for you. Can you see the image, the two images in front of you? The first image is diffuse glomerulosclerosis and second is nodular glomerulosclerosis, right? Both of them are seen in diabetic kidney, diabetic nephropathy, okay? Diabetic as a diabetes complication. Now, why one is diffuse and why one is nodular? I can see one glomerulus here. I can see one glomerulus here. Now, what is the problem? What is the problem in both of them? The problem is that whenever there is more glucose in the blood for years, you know the normal range of the glucose. If the more glucose in the blood, that is the person is having diabetes, whether type 1 or type 2, it is not treated for 5, 10, 15, 20 years, the kidneys will get damaged. In the kidney, hyaline will get deposited. What is hyaline? Hyaline is pink color, acellular structureless material. I repeat, hyaline is pink color, eosinophilic matlab pink color, acellular structureless material which will deposit in the kidney in case of diabetes. So in both of them hyaline is deposited, but where it is deposited? In diffuse it is deposited at 4 places. Let me show you here. Can you see the mesangium at the center? You see this is mesangium, the pink color material at the mesangium. So number 1, it's known as mesangial deposits. Where it is written mesangial deposit. The hyaline is deposited in the mesangium. Number 2, it is deposited in the capillaries, the basement membrane of the capillaries. See, the basement membrane is pink thickened. You know, the basement membrane is more pink, more thickened. It is known as thickening of the GBM, number 2. Number 3, it is deposited in the cap of the capillary. Can you see a cap? Cap in a topi. You know, cap. So capillary have worn a pink color cap. This capillary also have a pink color cap. It is the hyaline. It is known as fibrin cap. And number 4, it is deposited in the capsule, the Bowman's capsule. Can you see the pink color deposits here? It is known as capsular drop. Bowman's capsule. That's why it is known as diffuse. Diffuse means the hyaline is deposited at 4 places. In the mesangium, in the GBM, in the capillary cap and in the Bowman's capsule. That's why it is known as diffuse. Everywhere hyaline is deposited. In all the 4 places it is hyaline only, the pink color material. Okay. This is known as diffuse. Coming on the nodular. In the nodular one also hyaline will deposit, but not at 4 places. It will deposit it in the form of the nodule. In the mesangium, that's it, in the form of the nodule. Appreciate the nodules. Chote nodules banayega, circle, oval nodules. So that's why it's known as nodular. It's not diffuse, it's nodular. So please appreciate the meaning of the diffuse and nodular. In both of them, the pink color hyaline is deposited, but in diffuse it's everywhere. At 4 places you can learn everywhere, but in nodular it's in the form of small nodule. It's not diffuse, it's nodular. Say yes, how many of you got it? So that is the meaning of the diffuse and nodular, the 2 type of hyaline deposition. Both of them are seen in diabetes mellitus. So I repeat, whenever the glucose level in the blood is more for years, the hyaline will form and hyaline will deposit in the kidney. It will deposit either in diffuse manner, everywhere in the glomerulus at 4 places or it is in the form of the nodules. Okay, say yes. Say yes, you got it. So the nodular one have a peculiar name. The nodular one is known as Kimmelston-Wilson kidney. I will show you the name. This is known as Kimmelston-Wilson kidney, KW kidney, the scientist who discovered it. And it's a very important PYQ. So instead of giving you the word nodular glomerulosclerosis in your exam, you will get the question on KW kidney, Kimmelston-Wilson. So basically they are talking about the nodular one. Now let me tell you, is it buffering or you can see it? Someone is saying the video is buffering. Krishnan, what about others? Paras, Osama, Anbu. It's normal. Okay, so maybe you check your internet connection, the students who are getting it buffering. So I repeat, so in both the forms, both of them are seen in diabetes. Listen, both of them are seen in diabetes mellitus. Okay, sometimes this is seen, in some patient this is seen. Okay, both of them, in both of them the hyaline will deposit inside the glomerulus. But where the hyaline is deposited, it is deposited everywhere. It's known as diffuse. It is deposited only in the form of nodules, small circular nodules. It's nodular. The nodular one have a peculiar name. It's known as Kimmelston-Wilson kidney, the scientist who discovered it. Now you should ask me, ma'am, which is more common? You said that both occur, but which is more common? So more common is diffuse. But if I say which is more specific or which is more characteristic, so more specific or more characteristic is nodular. So please read your question very carefully in your exam. If they are asking which is more common in diabetes, so answer is diffuse glomerulosclerosis. And if I say which is more characteristic, so answer become nodular. Say yes. You got it? Say yes if you got it. Okay. So this is the thing. This is how you have to appreciate the two type of glomerulonephritis. This one is more common and this one is more specific or characteristic for the diabetes. So let's solve some PYQs on that and come on the hereditary glomerulonephritis. We are done with secondary also. Most common pathological feature in diabetes mellitus. They are asking common. Is it papillary necrosis? Is it diffuse glomerulosclerosis? Is it renal atherosclerosis or chronic pyelonephritis? What is the correct answer? What is the correct answer? Yes, Paras, absolutely right. Yes, you all are right. It will be diffuse. If I change the question, instead of most common, if I ask you most characteristic or most specific, the option is not given. I'm sorry. In that case, it will become nodular. Okay. The next question. KW kidney is seen in. Is it seen in HIV? Is it seen in diabetic nephropathy? Is it seen in SLE or malignant hypertension? The question is super simple because just now I taught you diabetes and the KW kidney I am asking. But imagine if I teach you complete and then ask the same question, become difficult for you. The correct answer is diabetic nephropathy. Everyone knows. Next question. What is KW kidney? What is KW lesions? कि Milston-Wilson lesion का मतलब क्या होता है? Is it splitting of glomerular basement membrane? Is it nodular sclerosis of the glomerulus? Is it hyaline sclerosis or is it hyperplastic arteriosclerosis? Yes, you all are right. It is the nodular hyaline deposits in the entire glomerulus, right? The next and the last question, most specific finding in diabetic nephropathy. I am asking specific, not common. Please mind my words. I am asking specific. Is it crescents formation? Is it immune complex deposition? Is it occlusion of the glomeruli with fibrin caps or is it nodular glomerulosclerosis? What do you say? Yes, Kuldeep. Absolutely right. Absolutely. So correct answer is nodular. Most specific is nodular. Here complex nahi bante hain. Okay. Let's come on the hereditary nephritis. We are done with the primary. In the primary, I taught you nearly 9 glomerulonephritis. In the secondary, I taught you 1, the diabetic one. And in the hereditary, there are 3. But I will teach you only 1, which is ultra important. In the hereditary, the 3 are Alport, Fabry, and Neil patella. So we will come with Alport. We will see the details of the Alport. So let's start Alport syndrome. Okay, what is Alport syndrome? Alport syndrome is hereditary nephritis. It is hereditary. It is congenital. It is hereditary. So what is the pathogenesis? There should be some gene which is mutated. No? So what is the name of the gene which is mutated? So you know type 4 collagen. Type 4 collagen, the basement membrane is made up of type 4 collagen, right? So for that there is a gene. The gene is COL4A5. So type 4 collagen have alpha 5 chain. Alpha 5. There are multiple alpha chains. Alpha 1, alpha 2, alpha 3, alpha. So alpha 5 chain of type 4 collagen, the gene for that is mutated. Congenitally it is mutated. It is known as collagen ka gene mutated. Collagen type 4 ka alpha 5 gene. So it is known as col matlab collagen. Collagen type 4 ka alpha 5 gene, A5 gene is mutated, right? And it is an X-linked dominant disorder. You know, whenever there is a congenital or hereditary disease, there are 4 types of inheritance. I guess everyone know. Autosomal dominant, autosomal recessive, X-linked dominant, X-linked recessive. So currently for Alport, it is X-linked dominant. Very few diseases have X-linked dominant inheritance. Alport is one of them. Please learn that. It is more common in males. That's why it is more common in males. The patient have typical triad. As soon as, imagine a child is born, the child is deaf. Number 1, the child is deaf. Number 2, the ear is involved, the child is deaf, the eye is involved, the eye of the child. In the eye, you will see cataract, you will see corneal dystrophy. Cataract in the lens of the eye, corneal dystrophy in the cornea of the eye, and the lens is dislocated also. So these are the ocular complication. And if you see the kidney, the patient have nephritic syndrome, right? The kidney is also damaged, the patient have Alport. This is the triad of the Alport. Say yes, this is the triad of the Alport. So what is the triad of the Alport? Can you say it again for me? What is the triad of the Alport? Eye complication, ear complication, kidney complication, right? So eye may, what will happen? The patient have cataract, the patient have lens dislocation and corneal dystrophy. Okay. What will happen in the ear? Sensory neural deafness. And what will happen in the kidney? Nephritic syndrome. Give me 1 minute. Power cut off, so there is some sound. Let me, from the inverter, let me fix it. Give me 1 minute. I guess it is fixed. Okay, so can we continue? So that is Alport syndrome, you can see. In the Alport syndrome, you can see the typical triad is in front of you. You get many questions on Alport, right? So what do you do in the diagnosis? Imagine you are a pediatrician. Imagine a child is born today, right? And after some days, the parents are coming to you, doctor, my child cannot hear. Whatever we are doing some sounds, we are doing some noise, the child is not responding. So if you are checking, the child is having sensory neural deafness. Number 1. If you are checking the eyes, you are getting the cataract in the eyes. and you are getting the lens dislocation also. You are getting the corneal dystrophy also. So you have a suspicion this child is having Alport syndrome, right? So you will do the kidney biopsy. You do the biopsy of the kidney. You cannot do the biopsy of the ear. You cannot do the biopsy of the eye. You can see them clinically, right? But for confirming, you will do a kidney biopsy. What you will get on kidney biopsy? What you will do on a kidney biopsy? In the kidney biopsy, the light microscopy is not a very confirming. So the light microscopy is same as that of APGN. The size is more, the proliferation is more, but cellularity is more. But electron microscopy is hallmark. No other disease have this hallmark feature in the electron microscopy. In the electron microscopy, what you will see now, let me explain you. Let me try to draw. You have a basement membrane. Normally basement membrane is present in the center, and there is endothelium and there is epithelium, right? There is epithelium. It's like this, right? Here in Alport syndrome, in the basement membrane, there is alternate dark light, dark light, dark light, dark light band. Alternate thickening, attenuation, thickening, attenuation. इसको कहते हैं alternate thickening attenuation pattern in the basement membrane. It is typically seen only in one disease in this world, that is Alport. So Alport electron microscopy is hallmark. It looks like a basket. I don't know, do you have this basket at your home? I'm having for vegetables. It's like basket like this. Have you seen this basket? I forgot to put from the Google image of this. It's a basket appearance. Have you seen this basket? Alternate dark light band we have, like for vegetables or something we use. It is typically known as basket weave appearance, weaving basket. You got it? Say yes. So you can see the electron microscopy. If you see it carefully, you can see alternate dark light band. It is known as foci of thickening alternating with attenuation. This is typical appearance of Alport, on which many questions comes in your exam. That is the Alport syndrome, right? Immunofluorescence, no deposits are there, right? So what is the earliest symptom? Although you know the triad, in the triad, eye is involved, ear is involved, but the earliest symptom is hematuria. Patient presents first with hematuria. What is the extrarenal abnormality? It is sensory neural deafness is the first abnormality. And what is the hallmark feature? Electron microscopy is the hallmark feature, on which you get a basket weave appearance. I guess you understand the meaning of the basket weave. It's alternate dark light band. Can we go ahead? Yeah. What we have learned of Alport, can we revise it quickly? Who will help me? Alport syndrome. What is Alport syndrome? So write down, Alport syndrome is one of the hereditary nephritis. It is not primary, it is not secondary, it is hereditary glomerulonephritis. So if it is hereditary, it should have some pattern. Is it autosomal dominant? No. It is autosomal recessive? No. Is it X-linked recessive? No. It's X-linked dominant. That's why males are more involved as compared to females, because of the X-linked dominant pattern. Because, okay, and what is the name of the gene which is mutated? So the name of the gene which is mutated is collagen 4 gene. कोलेजन टाइप 4 कोलेजन का जो जीन है उसमें अल्फा 1, अल्फा 2, अल्फा 3, अल्फा 4, अल्फा 5 चेन A5. So this is the name of the gene, COL4A5. This gene is mutated. Now since this gene is mutated, there is a typical triad. Patient presents with 3 complaints. Number 1, the ear is involved. Number 2, the eye is involved. And number 3, the kidney is involved. Ear, patient have sensory neural deafness. In the eye, patient have cataract, dislocation and corneal dystrophy. In the kidney, patient have glomerulonephritis, which presents as nephritic syndrome, not nephrotic syndrome, right? Now, among the 3, which is the earliest presentation, if you ask me, it's hematuria. Extrarenal earliest manifestation, it's sensory neural deafness. And last will come the eye complication. For diagnosis, no biopsy of ear, no biopsy of eye, you take biopsy of the kidney. So do a kidney biopsy. So in the kidney biopsy, you do 2 things. You do all 3 microscopy: light microscopy, electron microscopy, immunofluorescence microscopy. Immunofluorescence, no deposits. Light microscopy, it's increased size, increased proliferation, increased cellularity. But electron microscopy is hallmark. It is the hallmark, I repeat my words. So here you get typically alternate thickening, thinning, that is basket weave appearance. So this is the complete of Alport. You get all the questions from this. Give me a thumbs up. You give me appreciation that you got it. Give me an indication. Can we go ahead? So we will solve some questions on Alport. So hereditary nephritis is seen in. I told you 3 diseases of hereditary nephritis. Is it analgesic nephropathy? Is it Balkan nephropathy, Alport syndrome, or eosinophilic nephritis? What is the correct answer? What is the correct answer? Yes, you tell me. What is the correct answer? So yes, the correct answer is the Alport, of course. So there are three hereditary nephritis: Alport, Fabry, Neil Patella. So among them only one is given. So glomerulonephritis associated with sensory neural deafness. So glomerulonephritis, that is kidneys involved, and ear, sensory deafness, sensory neural deafness is there. It is seen in which disease? Is it seen in Alport, Nail patella, Down syndrome, or Fabry disease? Yes. The correct answer here is Alport. Very good. The next question, not true about Alport. Tell me one thing which is not true about Alport. Tell me one thing. Is it X-linked? Is it true or false? Is it autosomal dominant? Is it true or false? Is it nerve deafness? Is it true or false? Or glomerulonephritis occurs? Is it true or false? Yes, you all are right. Absolutely right. Superb. So correct answer is B. It never autosomal dominant. It is X-linked dominant. So this is right. Sensory neural deafness also occur. Glomerulonephritis also occur. But autosomal dominance cannot occur. Okay. Nerve deafness is sensory neural nerve deafness. No, it occurs. Okay, it occurs. So coming on the next disease here, we are done. Congratulations, we are done with glomerulonephritis. So most of the glomerulonephritis maximum question, I guess all the questions you can cover from this session. So let's come on the next disease in the renal system, that is renal cystic disease. So let's come on the next disease. The next disease here is the renal cystic disease, also known as polycystic kidney disease. Right, it is known as PKD, polycystic kidney disease. Actually, it's a disease in which the entire kidney converts into cyst. देखो नाम में ही है, नाम क्या है? Polycystic kidney disease. What do you mean by polycystic? The entire kidney converts into cyst. The kidney disappears. Instead of which multiple small cysts are formed. This disease is known as polycystic disease. Now it is of two types. It can occur in adults also. In the 3rd to 4th decade of life, it can occur in infants also within 1 year of life, right? So it is of two type, adult type, infant type, depending on the age of presentation, right? Adult type is always autosomal dominant and the infant type is always autosomal recessive. That's why the adult type is known as ADPKD. Say, what is the full form of ADPKD? It's ADPKD. It's autosomal dominant polycystic kidney disease, that is adult type. And the infant type is always autosomal recessive, ARPKD. See the full form? Autosomal recessive polycystic kidney disease, it is the infant type, right? So in both of them the gene is mutated. You have to learn the name of the number of the chromosome and the exact name of the gene which is mutated in both of them. Both of them are hereditary, right? The only thing that presents in adulthood and that presents in childhood, that is the only thing, right? In both of them the disease is the same. The kidney get converted into the cyst. One more difference, in adult type the cysts which are formed is spherical. They are spherical. The entire kidney is spherical cyst. In infantile type also the cysts are formed. They are cylindrical. Radiating from the cortex till pelvis. So the cylinders are radiating from cortex to pelvis, giving the kidney a sponge-like appearance. In both of these diseases, I will tell you the exact chromosome and the gene which is mutated. The cysts are present in liver also along with the kidney. And in adult type, the cysts are present in the brain also, which is known as Barry aneurysm. So that is the overview. I have given you the two diseases, that is polycystic kidney disease, renal cystic disease. In both of them, the major portion of the kidney get converted into cyst, right? So there are two type of PKD. One is autosomal dominant, one is autosomal recessive. The autosomal dominant presents in adults and the autosomal recessive presents in infancy, right? Here the two chromosomes are involved. In autosomal dominant, chromosome 16 and chromosome 4. Okay, I guess everyone knows, just a second. Okay, 16, 4 and 6. Everyone knows that humans have how many chromosomes? Humans, diploid cells have how many chromosomes? I guess everyone knows it's 23 pairs. Either you say 23 pairs or you say 46 chromosomes, right? 23 pairs, 46 is one and the same thing. This is pair number 1, pair number 2, pair number 3, 4, 5. Likewise, we have 23 pairs. Let me draw two cells, the kidney cells in front of you. Let me draw the two kidney cells in front of you. This is the first cell. This is the second cell. Here I am trying to draw ADPKD pathogenesis. Here I am trying to draw ARPKD pathogenesis. I mean this one is the adult, I mean this one is the infantile. Okay, this one is autosomal dominant, this one is autosomal recessive. So in the first one I am interested in pair number 16 and pair number 4 out of the 23 pairs, and here I am interested in pair number 6. That's it, right? Now tell me the name of the gene. Here two genes are mutated. This on chromosome number 16 it's PKD1 gene. On chromosome number 4, it's PKD2 gene. So either PKD1 or PKD2, if they are mutated, they will lead to ADPKD, right? They will lead to ADPKD. And on chromosome number 6, only one gene is present. It is known as PHKD gene. It is not 1 and 2. PHKD gene. If it is mutated, it will lead to ARPKD. Give me a thumbs up if you got it. Please learn the number of the chromosome and the name of the gene. Please learn the number of the chromosome and the name of the gene. I repeat, in adult one, in autosomal dominant one, the two chromosomes are involved are 16 and 4. and the name of genes is PKD1, PKD2. In autosomal recessive, the infantile one, only one chromosome is involved. The number of the chromosome is 6, and the name of the gene is PHKD. In both of them, if this particular gene is mutated, here also the kidney converted into cyst of spherical cyst. Here also the kidney converted into the cyst, but the cysts are radiating sponge-like. So that is the thing. This one present in 3rd to 4th decade of life, 30 to 40 years. This one present in 0 to 1 years of life. That is the thing. Everyone appreciate and give me a thumbs up. That is PKD, the simplest way I can teach you. Okay. So please see the number of the chromosome 16,4. Here the gene is PKD1, PKD2. Here the number of the chromosome is 6 and the name of the gene is PKHD. Okay. And cysts are formed in the liver also. Cysts are formed in the brain also. In the brain there is Barry aneurysm in ADPKD. Can we go ahead? So we have seen the two type of PKD, ADPKD, ADPKD. Here 16 and 4 chromosome, PKD1, PKD2, it's autosomal dominant. Both the diseases are bilateral, both are diffuse. So whether you talk about ADPKD, whether you talk about ARPKD, in both of them, both kidneys are involved. Both of them are bilateral. None of them is unilateral. The only difference here, the spherical cysts are there, and here cylindrical cysts are there, right? But both of them, I mean to say, it's bilateral. Both of them are bilateral. This one adult, this one infantile. Give me a thumbs up. Got it? Right. So both of them are bilateral. I hope we have done. We will solve some questions on that and move to the next disease. Adult PKD is seen in. Can you tell me the answer, please? Adult PKD is seen in. Yes. What is the correct answer? Is it autosomal dominant or autosomal recessive? I am asking for adult. Or is it X-linked or mitochondrial? Am I visible, audible? Why you people are not responding? Anyone? What is the correct answer? Yes. So I am asking the adult. The correct answer is A. You all are right. Yes, it's autosomal dominant. Absolutely right, Osama. Everyone. Very good. Very good. The correct answer here is A. Okay, be fast in your answers. Na? The next question. Which of the following is associated with adult PKD? Tell me. Is it Barry aneurysm? Or saccular aneurysm of aorta? Is it fusiform aneurysm of the aorta or lutic aneurysm? Which aneurysm is associated with adult PKD? Adult polycystic kidney disease. Yes, you all are right. It's Barry aneurysm in the brain, in the circle of Willis. One more last question. Which of the following statement is wrong for ADPKD? For adult type, which of the following is wrong? Can you read the question and tell me what is the correct answer? Kidneys are enlarged in size. Is it true or false? The presentation is unilateral. Is it true or false? Intracranial aneurysm, Barry aneurysm are seen, and the disease typically present in 3rd decade. You all are right. Yes, Dipanshi, Osama, Vikrant, everyone is right. The correct answer is unilateral. It never unilateral. Both of them are bilateral. Okay, we are done. Okay, so for tumors, I'm skipping the tumors here. So I told you I'm going to launch the oncology series. In the oncology series, I'm going to teach you entire tumors of body at one place. So here if I teach you renal tumors, the lung tumors, they will be scattered. So what is the plan now? In oncology series, I will start from the head. I mean, I will teach you the brain tumors, the eye tumors, the nose tumors, you know, the tonsillar tumors, the oral tumors. Then we will come on the lung, then we will come in the pelvis, the male genital, the female genital, you know, all tumors of entire body. Pathology point of view, I will teach you the pathology, like the microscopy, the Grothendieck microscopy of all the tumors, the types at one place with the staging, right? So oncology series are soon going to launch. If you wish, we can launch it, like if it is in demand, if you want. So all the tumors will be at one place, will be dealt with better. So here I am skipping the tumors of the kidney. Give me a minute. Give me a minute, and moving to the next unit, that is respiratory unit. So you tell me when to launch. If you wish, if you most of the students require that, we can launch it soon. Last time also I asked you, if you want the oncology series, we can launch it. It will be very, very useful for all the students, right? All tumors at one place will be, you know, super easy for you. Just a second. Let's move to the respiratory system. Okay, time is less now. We have to cover more in less time. So we want to be more productive in less time. Let's start respiratory system. Can we go ahead? Okay, definitely Aisha, we can do that. We can do that. We can plan as soon as possible. Okay, so let's start respiratory system quickly. In the respiratory system, we will do the COPD. First, we will cover the 4 types of COPD. That is the ultra important topic, and definitely you are going to get questions on COPD. So let's start COPD. What is COPD? Chronic obstructive pulmonary disease. COPD. Chronic obstructive pulmonary diseases are there. So what do you mean by chronic obstructive pulmonary disease? To explain you chronic obstructive pulmonary disease, let me draw a respiratory tract in front of you. The respiratory tract start with the nose. Let me start with the nose. Can you see it is starting from with the nose. With the nose we inhale. So with the nose, behind the nose, we have pharynx. It's nasopharynx, oropharynx. The pharynx lead to larynx. This is larynx. The larynx lead to trachea. This is trachea. The trachea leads to bronchi. These are bronchi. The bronchi leads to bronchioles. First we have primary bronchioles that lead to secondary bronchiole, that lead to tertiary bronchiole, that lead to terminal bronchiole, that lead to respiratory bronchiole, that lead to alveolar duct, and finally alveolar sac, that is acinus. So you have to learn this sequence. I repeat, start from the nose, then there is pharynx, then there is larynx. This is larynx. This is pharynx. Then there is trachea. Okay, this is trachea. These are bronchi. The two bronchi you can see, the left and the right, the primary bronchi. Now bronchioles. Bronchioles में क्या क्या है? Primary, secondary, tertiary. Tertiary के बाद आ जाएगा terminal bronchiole. Okay, terminal bronchiole will give rise to respiratory bronchiole. Respiratory bronchiole give rise to alveolar duct, or alveolar duct give rise to alveolar sac. Alveolar sac also known as alveoli. Finally alveoli. The last three structures here. What are the last three structures? These three. I'm talking about these three. Let me highlight. Respiratory bronchiole, alveolar duct, and alveolar sac. These three structures together known as acinus. What it is known as? Acinus. So most of the students have confusion, ma'am. What is acinus? What is acinus in the lung? So this is the acinus in the lung. The acinus is the structural and functional unit of the lung. Like glomerulus is the structural and functional unit in the kidney, na? In the lung we have acinus. It is the structural and functional unit of the lung, right? Now we divide the respiratory tract into two parts, the upper and the lower. So the cutoff is the trachea. Above the trachea it's upper respiratory tract, and below the trachea it's lower respiratory tract, right? Let's talk about the disease, the COPD. COPD, right? Let's talk about the disease, the COPD, chronic obstructive pulmonary disease, right? In chronic obstructive pulmonary disease, there is obstruction in the lower respiratory tract anywhere, starting from the trachea till acinus. If there is obstruction anywhere, the obstruction is chronic, it is known as COPD. Now, I will teach you four COPDs here. Listen, I will start with chronic bronchitis, then I will come on emphysema, then I will come on asthma, and then I will come on bronchiectasis. This is bronchitis, this is bronchiectasis. I'm pronouncing it very clear, you don't have any confusion. In all of them, one thing is common, that there is obstruction, but the level of obstruction will be different. I mean to say, in chronic bronchitis, I will do the obstruction in the trachea and bronchi. In emphysema, I will do the obstruction in the acinus, the last portion. In asthma, again I will do the obstruction in bronchi. In bronchiectasis, I will do the obstruction in the bronchioles. So you know the level of the obstruction in all four will be different, and not only this, the level will be different, and the reason for the obstruction will be different, and microscopy will be different. So that is an overview of the COPD. What is COPD? So Anbu, definitely I will launch the PSM series also. Wait a while, maybe in the next 3-4 days it will be launched. Okay, so don't worry. So currently focus on the pathology. Can we continue? Can we continue? Okay, so I told you the level of the obstruction will be different. So here you can see the level of the obstruction in the trachea and the bronchiole. Chronic bronchitis and asthma, it is in the trachea and the bronchioles. In bronchiectasis, it will be in one of the bronchiole, and in emphysema, it is in acinus. So the level of obstruction is different, but in all of them, one thing is common, they all are COPDs, they have some obstruction. So this is the complete sequence, the same thing is written in front of you. So here the lower respiratory tract is shown to you. So first there is trachea. From the trachea, the two bronchi come, the right and the left. The two bronchi में से आएंगे bronchioles. First primary bronchiole, then secondary bronchiole, then tertiary bronchiole, then terminal bronchiole. Terminal bronchiole के बाद respiratory bronchiole, alveolar duct. पहले alveolar duct आएगा, फिर alveolar sac आएगा, है ना? It should be duct here, it should be sac here. And the last three things together is known as acinus. Okay, I hope everyone got it. Kindly appreciate. So let's start COPDs. The 4 COPDs in your syllabus: chronic bronchitis, emphysema, asthma, and bronchiectasis. We will see them quickly. Let's start with chronic bronchitis. Let's start with chronic bronchitis. Okay, in the chronic bronchitis, what is the problem? You know, let's start with trachea and bronchi. In the trachea and bronchi, what is the problem? Let me draw. This is trachea. This is bronchi. Can you see trachea and bronchi? You know, trachea and bronchi have four layers. Trachea and bronchi have the mucosa, submucosa, muscularis propria, and serosa. Okay, so let me draw the mucosa. This is the mucosa of the trachea and the bronchi. Okay, just below that we have submucosa. This is submucosa. Just below that we have muscularis propria. So this is muscularis propria. And after that, the outermost is the serosa. So this is the serosa. So likewise, we have complete 4 layers. In the submucosa, we have glands. I guess everyone knows the glands are there in the submucosa. What is the function of these glands? These glands do secretion. That is secreted in the lumen. So you know, the entire respiratory tract have sticky secretion inside that. Inside the nose, the human nose, there is a sticky secretion. The same sticky secretion continues throughout the respiratory tract, and that secretion is done by the glands which are present in the submucosa. I insist to learn these glands which are present in the submucosa that do the secretion. The secretion is very necessary for humans, right? So whenever any dust, foreign particle enters, that will stick in the secretion and that will not unable to go inside, right? So that is the thing, right? Now what is the problem here? That God has given the respiratory tract to inhale and to exhale to do the respiration, but some people smoke, some people misuse the respiratory tract. The respiratory tract is not for smoking. Some people smoke. Because of the smoke, when the smoke goes inside, what will happen? That will irritate the wall. The smoke will irritate the tracheal and the bronchial wall. So because of irritation, that is acting as a stress. You know, in pathology, in chapter 1, general pathology, I taught you adaptation. So whenever there is a stress on any organ, the organ adapt, you know. So on the trachea and in the bronchi, the smoke is causing a stress. So it will do the adaptation. The 5 type of adaptations you will be knowing: hypertrophy, hyperplasia, atrophy, dysplasia and metaplasia. So currently here, the smoke is causing the stress on the wall of the bronchi and the trachea. In response to that, the wall will do the adaptation. So the submucosa, the glands in the submucosa, they will do 2 type of adaptation: hypertrophy and hyperplasia. They will increase in number and they will increase in size. They will increase in number, they will increase in size. Why they are increasing in number and size? In response to the smoke. Since they increase in number and they increase in size, they show hypertrophy as well as hyperplasia. They do more and more and more secretion. So the lumen is completely packed with the mucus secretion that will cause the obstruction. So the reason for the obstruction is the mucus plug. Here a mucus plug is formed. The mucus plug is formed by the excessive secretion from the glands. The glands are doing excessive secretion because there is abundance of, there is hypertrophy and hyperplasia. Say yes, all of you. Okay, can we go ahead? Yes. So that is the thing. So that is the reason. So can you tell me the level of the obstruction? The level of the obstruction is trachea and bronchi. Can you tell me the reason for obstruction? The reason for obstruction is the mucus plug. Why the mucus plug is formed? Because the glands are doing excessive secretion. Why the submucosal glands are doing excessive secretion? Why they are doing? Because they are showing hypertrophy and hyperplasia. Why they are showing hypertrophy and hyperplasia? Because of smoking. So complete story start from the smoking. The person who smoke, because of which the smoking is causing the stress. Because of the stress, the submucosal glands, they will do the adaptation. They will do hypertrophy and hyperplasia. I mean to say, they increase in size, they increase in number, because of which they increase the secretion. More and more secretion will cause the plug, the mucus plug, that will lead to obstruction. So please make this flowchart. This is chronic bronchitis. Now such patient, what they do, the complete trachea and the bronchitis filled with the mucus plug, they can't respire. They can't respire, so they will have dyspnea. So most common complaint, they have cough, they try to cough every time they cough. Why they cough every time? Because they try to remove the mucus plug out of them, right? So cough is with abundant of sputum. Abundant, it is not dry cough, it is the expectorant, it is the sputum wala cough. So patient cough every time and try to remove the mucus plug in the sputum every time he cough, or every time he do the throat clearing like that because there is abundant of mucus plug in the entire respiratory tract, especially the trachea and the bronchi, right? So cough is the most common complaint. Second most common complaint is dyspnea. The patient will have dyspnea because patient can't respire. So these are the 2 important complaints this patient will have. That is the chronic bronchitis. So what is chronic bronchitis? What is the definition you will say? So these are the patient who have persistent cough with expectoration. I mean to say, what do you mean by expectoration? Expectoration means sputum. What is expectoration? It's sputum. So it's chronic cough. Just a second. I cannot see your chat. Let me open. Okay. So it is chronic cough along with the sputum for most of the days. At least from last 3 months, the patient have constant cough. It is not going, it is not treating. And from last 2 consecutive years, the patient have the same history. Usually these are the males who are smoker. Okay. The pathogenesis is over-secretion. The over-secretion of the mucus due to increase in number and size of the glands in the trachea and the bronchi. Okay. Microscopically, if you see, so here you can see the 2 diagram. You can see this is normal, this is chronic bronchitis. Please everyone here, back to back, I will show you all 4 layers. Compare mucosa of both, compare submucosa of both, muscularis propria of both, and serosa of both. We will do the comparison. And maximum changes will be seen in the mucosa. We will do the comparison. The diagrams are in front of you. Everyone here on the screen. Can you see this is mucosa? See the mucosa here? This is normal, huh? And see the mucosa here in chronic bronchitis. What change you can see? See the goblet cells. Can you see only two goblet cells here? Here 1, 2, 3, 4 multiple goblet cells. So basically in the mucosa, goblet cell hyperplasia is there. Goblet cells are increased in chronic bronchitis. Main change is in submucosa. Compare submucosa at both places. See, this is submucosa here, this is submucosa here. Compare it. Please compare. Now in the submucosa, count the number of the glands. Can you see how many glands? 1, 2, 3, 4, 5, 6. And here 1, 2, 3, 4, 5, 6, 7, multiple glands. So I can see the gland number is increased, their size is increased. So basically in the submucosa, glands are showing hypertrophy and hyperplasia. Otherwise the muscularis propria and serosa, there is no change. So maximum change is seen in submucosa. Everyone appreciates, say yes if you got it. Now here I would like to explain you an index that is known as Reed index. Reed index kya hota hai? I will explain you. All index, Reed index. Reed index is an index. So like all index, it is having a numerator, it is having a denominator. So let me explain you what is the numerator, what is the denominator, for which I would like to draw this diagram for you. Okay, the same diagram which is drawn here. Give me a minute. So you can say this is the mucosa. I am drawing both the places. Mucosa hardly have any change, only apart from goblet cell hyperplasia. Main change is in submucosa. This is the submucosa. Okay, this is muscularis propria, both the places, which is same, and this is serosa. Okay, so main change is in submucosa. What is the change? You tell me. What is the change? So here glands are few, here glands are multiple. They increase in number as well as size. Agree or don't agree? Do you agree with me or don't agree? So what is the Reed index now? This is normal, I am drawn. The 4 layers, and this is chronic bronchitis, the 4 layers I have shown to you. So what is the Reed index? The numerator is the thickness of the glands upon total thickness of the submucosa. The thickness of the glands you see here, it is only this portion. So this is the numerator, the thickness of the gland, that is, I will say this portion A, and the total thickness of the submucosa is B. So A upon B, here C A upon B, and here C A, this is A. The thickness is increased now because number and size is increased, but B is same, right? So here, so compare A upon B at both places. So B is same. I mean to say the portion B is same in both of them. Here also total thickness is same. Here also total thickness is same. But the thickness of gland is increased in chronic bronchitis. See the thickness here and see this thickness here. So the numerator is more, denominator is same. So Reed index increases in chronic bronchitis. That is the conclusion. If you got it, it's good. If you didn't got it, learn that Reed index is increased in chronic bronchitis because numerator is more. Are you people there? Are you getting it? Are you getting it? Is there some disturbing sound in the background? The Kunj is saying, what is the disturbing sound? I don't have any sound here. Is my voice clear? Sound clear? Video clear? Audio clear? Are you people there? Can someone kindly respond, please? You got it? What is Reed index? What is Reed index? What is the numerator? What is the denominator? So in Reed index, the numerator and denominator, the numerator is the thickness of the gland. The denominator is the total thickness, right? Now since there is hypertrophy and hyperplasia, so numerator is increased but denominator is same. The numerator is increased and denominator is same. That's why the Reed index is increased. So that is regarding chronic bronchitis, right? The clinical feature, I told you the 2 main clinical feature. What are the 2 main clinical feature? The persistent cough with expectoration. By expectoration, I mean sputum. And number 2, dyspnea. So because of the dyspnea, the patient becomes bluish in color. That's why these are known as blue bloaters. These are known as blue bloaters. I am done with the first one. I have to teach you 4 COPDs. The first is done. Let me come on the second one. Before that, we will solve some MCQs on the first, that is chronic bronchitis. Can you tell me Reed index is useful in which disease? I taught you Reed index. Is it useful in glomerulonephritis or chronic bronchitis or cirrhosis or MI? Very vague question, a very easy question, I guess. Everyone can answer. Everyone can answer it. What is the correct answer here? Yes, the correct answer is the chronic bronchitis. The correct answer is the chronic bronchitis. There is some sound, buzzing sound. I don't know, maybe of my inverter. I don't know. Actually, I don't have any main sound here. Maybe technically some error is happening. I can't rectify it. I'm sorry. So let's continue with the same. Okay. Reed index is. Can you tell me what is the correct answer among it? Is it increased in chronic bronchitis, decreased in chronic bronchitis, increased in asthma, decreased in asthma? First decide the disease. Is it chronic bronchitis or asthma? Reed index. And it is increased or decreased in that particular disease. What is the correct answer? You all are right. Yes. The disease is the chronic bronchitis and it is increased. So Reed index is increased in chronic bronchitis. You all are right. Very good. Right. So correct answer is A. Okay. Can we go ahead? The next disease we are talking about here is the emphysema. So let's talk the next disease. The next disease is the emphysema. Okay. Just a second. What is emphysema? Emphysema is a disease of acinus. beyond terminal bronchiole. I told you the chronic bronchitis, it is a disease of trachea and bronchi. So here in trachea and bronchi, the submucosal glands is showing hypertrophy and hyperplasia, that is causing the chronic bronchitis. So I'm teaching you the next disease now, emphysema, the disease of the acinus. So see, the level is different. So what is happening in the acinus? Let me draw the acinus. What is the acinus? I told you, what is the acinus? In the acinus, three things are there. There is a respiratory bronchiole. From the respiratory bronchiole, multiple alveolar ducts are arising, and from the alveolar ducts, alveolar sacs are arising. These are the alveolar sacs. Let me write it. This is respiratory bronchiole, this is alveolar duct, the blue one, and the red one are the alveolar sacs or alveoli. Does anyone have any doubt in that? Now listen, this is the area which is compromised in emphysema, which is defective in emphysema. So what is the defect? Multiple acinus fuse with each other. Multiple acinus fuse with each other and they form the big balloons. The big balloons are known as bullae. Okay, so which is the point of the fusion? Let me tell you the types of the emphysema here. Let me tell you the types of the emphysema. Imagine only respiratory bronchiole is fusing, multiple respiratory. So respiratory bronchiole is dilating, but other portions are not dilating. So such emphysema is known as centriacinar. What it is known as? Centriacinar. Why it is centriacinar? The central portion is dilated, but other portions are not dilated. This is known as centriacinar. The second thing, the second type in which only alveolar sacs are fusing with each other and they form the big balloons, but other portion is not dilating. So only the last portion is dilating, that is alveolar sacs, but other portions are not dilating. It is known as distal emphysema. The second type is the distal. Okay. Third possibility, the complete sac is dilated. Complete sac is dilated, is known as panacinar. The third type is known as panacinar. And the fourth is the irregular. It is haphazardly dilated here and there, irregular. So can you tell me the four types of the emphysema? What is emphysema? Emphysema is a disease of acinus. So पहले समझ में आना चाहिए भाई acinus होता क्या है? What is acinus? What is acinus? So I told you now we have trachea. So this is the trachea. Lower respiratory tract starts from the trachea. Trachea gives rise to bronchi. Bronchi give rise to bronchiole. So in the bronchiole we have primary bronchiole, which leads to secondary bronchiole, which leads to tertiary bronchiole, which leads to terminal bronchiole. The terminal bronchiole leads to alveolar duct, respiratory bronchiole, which leads to alveolar duct, which leads to alveolar sac. So the last three portions here, the last three portions are known as acinus. So acinus, multiple acinus fuses with each other and they form big bullae, that is known as emphysema. Okay, now we will draw one acinus. So this is the respiratory bronchiole. These are the alveolar ducts which are coming out of it, and these are the alveolar sacs coming out of it. Okay, I hope everyone got it. Respiratory bronchiole, alveolar duct, and these are the alveolar sacs. Now which portion is dilating? Which portion is fusing with each other and dilating? Can you tell me which portion? So imagine this portion is dilating. Just a second. This portion is fusing and dilating. So this is known as centriacinar because the central portion is dilated. This portion is dilating. So this is known as distal emphysema because the distal portion is dilated. The complete is dilating. It is known as panacinar. Pan matlab complete is dilating. Or the last one is the irregular. The last one is the irregular. Can we go ahead? That is the meaning. So these are the four types of emphysema. Now what is the etiologenesis? You should ask me, ma'am, why? Any portion is fusing with each other, but what is the reason of fusion? Why they are fusing with each other and forming big. So this is one alveolar sac, other alveolar sac, other. So they all fuse with each other and they form a big balloon. Big balloon is known as bullae. Okay. So why fusion is there? So for understanding that, you have to understand the wall. The wall of the acinus, the complete acinus have a wall. The wall have two types of enzymes inside them. The wall. I'm talking about the wall of acinus have two types of enzymes inside them. What are the two types of enzyme? Protease and antiprotease. Protease and antiprotease are the two types of enzymes. Normally, what does the protease also known as elastase and also known as trypsin. Okay, antiprotease also known as anti-elastase and also known as antitrypsin. Okay, so that is the two type of enzyme. Normally, they are equal and opposite and regulate. So in all of the healthy individual, they are equal and opposite, right? So protease cause the degradation of the protein, antiprotease prevent that, right? So what happens? The person who smoke, the person, again smoking is the culprit. In them, all these will increase and all these will decrease. So there is an imbalance. The one who is degrading is increasing. The one who is protecting is decreasing. So there is an imbalance because of the smoking C. The protease is increased and antiprotease is decreased. So what will happen? So this is a wall, this is a wall, this is a wall. In all these walls, concentrate on the walls. So protease is more, antiprotease is less. So degradation will be more and defense will be. So they will fuse with each other, right? This is known as protease antiprotease imbalance. So that is the mechanism. You got my point? Classification, I already told you the 4 types: centriacinar, distal is also known as paraseptal, and panacinar and irregular. So here in centriacinar, only respiratory bronchiole is dilating. In distal one, only alveolar sacs are dilating. In panacinar, all 3 structures are dilating: respiratory bronchiole, alveolar duct, alveolar sac. And irregular is irregular. I hope I am crystal clear in my concepts. You got it? So you can see the same in the diagrams also. In all the 4 diagrams, you can see the acinus. In this acinus, the first one, appreciate the central portion is dilated. Only respiratory bronchiole is dilated. You can see this is respiratory bronchiole which is dilated. That's why this is centriacinar. In the second one, only the distal portion, alveolar sacs are dilated. That's why it is known as paraseptal or distal. In the third one, complete is dilated. All 3 structures are dilated. Respiratory bronchiole is also dilated. Alveolar ducts also dilated. Alveolar sacs are also dilated. This is known as panacinar. And irregular is haphazard. So give me a thumbs up. Now my next question, which is most common among the 4. You got the four types. Say yes or no. So for that, you understood what is acinus. What are the 3 components of acinus? If you understand what are the 3 components of acinus, you can understand the 4 types: centriacinar, distal also known as paraseptal, panacinar and irregular. So can you please help me in writing quickly? What are the 3 components of the acinus? Respiratory bronchiole, alveolar duct, alveolar sac. Okay, in centriacinar, only respiratory bronchiole is dilated. Okay, you can understand only respiratory bronchiole is dilated. In distal, only alveolar sacs are dilated. Okay, and here all 3 portions are dilated: respiratory bronchiole, alveolar duct, alveolar sac. Irregular is irregular. Now my next question, which is most common. Now there are two catch here. Most common, if you see, it is irregular. It is irregular. Overall, if you say most common, I will say answer is irregular. But point is that it is clinically silent. It don't present. It maybe I'm having, maybe you are having, maybe many of the persons having. But since it is clinically silent, we don't come to know that we have this disease. It don't present. It don't have any clinical symptom. So clinically present की बात करोगे तो centriacinar is most common. So centriacinar is most common if you talk about who presents clinically. But overall, most common histologically, if you say it's irregular. You got the 2 points. So 1-1 trigger, you have to learn of all 4. All 4 have 1-1 trigger. Let me tell you that trigger. Just a second. Okay. Here is the smoker. So centriacinar most common. Here the trigger is the smoking. It occurs in smokers, heavy smoker. The second distal, the panacinar, it occurs in alpha-1 antitrypsin deficiency. It's a congenital alpha-1 antitrypsin deficiency. Paraseptal maximum occurs in a patient which has having pneumothorax. Pneumothorax will be the trigger, and irregular occurs in the patient who is having the fibrosis. Okay, this one occurs in upper lung, this one occurs in lower lung, this one again upper lung, this one can occur anywhere irregular. So that's all about the 4 type of emphysema. We will make a table. Just read it. We will make a table in the end. So centriacinar, it is the most common type which presents clinically. It presents in the upper lung. Here only respiratory bronchioles are dilated, nothing else is dilated. It occurs in upper lobe and it occurs in heavy smoker. We are done. You can see this one, centriacinar. The second is the panacinar, in which everything is dilated. All the 3 things are dilated. It occurs in alpha-1 antitrypsin deficiency and it occurs in lower lung, the base of the lung. Okay, the third is the distal portion, in which alveolar sacs are dilated. It again occurs in upper lung and it occurs in pneumothorax patient, pneumothorax. And last is irregular. It is seen in scarring or fibrosis, and histologically it is most common but clinically silent. Do you have any doubt? Can we go ahead? So the same thing is written in front of you. Overall, irregular is most common but clinically silent. From the clinically presented one, the centriacinar is most common, right? So that's all about it, right? So we will solve some questions on emphysema and move to the third disease, that is asthma. After that, we will move to the third disease, that is asthma. So can we quickly solve some questions? The questions are in front of you. Can we quickly solve it? Emphysema pathologically involves beyond what? What is the definition of emphysema? You know the complete sequence now. What is the definition of the emphysema? Can you please tell me what is the definition, please? Is it beyond bronchi, beyond terminal bronchiole, beyond respiratory bronchiole, or beyond alveolar sac? I told you emphysema is a disease of acinus. Can you tell me the answer? Yes, absolutely right, Dipanshi. The correct answer is terminal bronchiole. I told you the complete sequence now. First of all, there is trachea. After the trachea, there are bronchi. Then primary bronchiole, secondary bronchiole, tertiary bronchiole, then terminal bronchiole, then respiratory bronchiole, then alveolar duct, then alveolar sac. You have to learn the sequence. What is acinus? The acinus is the last 3 portions. This is known as acinus. Emphysema is a disease of Acinus. Emphysema is a disease of Acinus. So it is a disease beyond what? The catch in the question is the word beyond. It is a disease beyond terminal bronchiole. Terminal bronchiole के बाद की तीनों चीजें. Beyond मतलब बाद, है ना? So the correct answer is terminal bronchiole. Everyone got it? The correct answer is B. The next question is in front of you. Commonest type of emphysema. Now please, again there is a catch in the question. Commonest type of emphysema. Is it centriacinar, obstructed, irregular or panacinar? What do you say? Who will give me the correct answer first? I'm asking overall commonest. I'm not saying anything clinically present or doesn't present. Overall commonest. So yes, no, don't say centriacinar, Kishan, Aisha. No, Varun, not obstructed. It will be irregular, no? Most common is irregular, I told you. But it is clinically silent, वो एक अलग बात है. But most common होता तो irregular है ना? In the world, it is most common irregular. Although it is clinically silent, but it is most common. But if I say most common type of emphysema which present clinically, then your answer will become A. In that case, your answer will become A. But currently, the answer is C. So all those who are wrong, who were saying A as the answer, got it. Why? Currently, the answer is C. Currently, if I say most common, answer is irregular. If I say most common which presents clinically, so answer will become centriacinar. You got it? Say yes. Give me a thumbs up. Okay. The next question is in front of you. Distension of distant alveoli is seen in. Please have a look on the question very clearly. Distension of the distal alveoli is seen in. Distal alveoli. Irregular, paraseptal, panacinar or centriacinar. I am asking the distal alveoli. So, yes, in paraseptal. Very good. So, I told you the types of the emphysema. The three things are there. Respiratory bronchiole is there. From the respiratory bronchiole, multiple alveolar ducts are coming out, and from them multiple alveolar sacs are coming out. So depending which portion is dilated, that will define the type of the emphysema. If the respiratory bronchiole is dilated, it's centriacinar, right? If our question is distal alveoli, that is alveolar sacs are dilated, it's paraseptal. That is our question right now. If complete is dilated, that will be panacinar, and irregular is Hephazard. Okay, so currently the answer is paraseptal and you all are right. So going to the next question, antitrypsin deficiency is associated with which one? I told you antitrypsin deficiency. Antitrypsin is an enzyme. If it is deficient, there is an imbalance between trypsin and antitrypsin, or protease antiprotease. So it is a hallmark of which disease? The pathogenesis of which disease? Is it respiratory lung pathology? Is it cystic fibrosis? Is it emphysema or is it carcinoma? What is the correct answer? You all are right. Yes, the correct answer is emphysema. Right. Let's move to the third disease quickly. That is asthma. We all have heard of asthma. What is asthma? Asthma is an allergy. Very good. Asthma is a type of allergy. It is a simply allergy. Okay. So what is the pathogenesis of the asthma? What do you mean by asthma? It's type 1 hypersensitivity. So what is happening in the asthma patient? What is the level of the disease? Again, it is a disease of the trachea and bronchi, like chronic bronchitis. So chronic bronchitis was here. Emphysema was here. This is the level of emphysema. Again, I am saying asthma is here only. This is asthma. So asthma is again a disease of trachea and bronchi. So what is happening in asthma now? There are few individuals, few persons which are hypersensitive. What do you mean by hypersensitive? I mean, if I'm inhaling any pollen grain, imagine there is some dust particles, some allergen, some pollen grain in the air, and I'm inhaling it. I don't have asthma, just suppose, and it is going inside. So the pollen grain, the dust, it will go inside. My nasal hairs will try to trap it. My macrophages will try to engulf it. We have cilia in the respiratory tract that will try to move it out, right? And ultimately, if we are successful, I mean, it will be stopped there. If we are not successful, ultimately it will go in the lung and the macrophages will engulf it, right? So this happens normally. But there are certain individuals which are very sensitive. As soon as any dust particle or pollen grain they inhale, their trachea and their bronchi is hypersensitive and they go in spasms. I repeat my words, they go in spasms. The trachea go in spasms and the bronchi also go in spasms. Why they are going in spasms? It's a protective mechanism. They try to they do not want the dust particle to go inside. They do not want the pollen grain to go inside. But by doing so, the patient can't respire. So at that time, whenever there is an allergen, the patient will have attack of asthma. So asthma is a paroxysmal disease. By paroxysmal, I mean the disease comes in attack. It's not constant. So patient have the attack, patient become normal. Patient have another attack, patient become, between two attacks, patient is absolutely normal. It's not like constantly the patient have the symptoms. No, at the time of the attack only patient have symptoms. So it is a disease. And when the attack will come only when the patient is exposed to the particular allergen. What is the allergen? Different person have different allergen. It can be dust, it can be certain chemical, it can be certain perfume, it can be certain pollen grain, it can be in particular season. So that is the allergen, right? So this is asthma. You got my point? So see the trachea and bronchi of a healthy individual and see the trachea and bronchi of an asthmatic individual at the time of the attack. At the time of the attack, it is going in spasm and that is causing the obstruction. Give me a thumbs up if you got it. That is asthma. So asthma is increased responsiveness of the tracheobronchial tree to a variety of stimuli. The stimuli is the allergen, which will lead to the spasmodic narrowing. Or spontaneously it will be relieved, or by therapy, the inhalers and the pumps are there, it will be relieved, right? That is asthma. So compare. The acinus is normal. There is no problem in the acinus, but it is a disease of the trachea and the bronchi. You can see it's a disease of the trachea and the bronchi. Asthma patients have 3 symptoms. They have paroxysm of the dyspnea. At the time of the attack, they can't do the respiration. They have dyspnea. They have difficulty in doing the respiration. They have cough and they have wheezing. So the triad of the asthma is dyspnea, cough and wheezing. Say yes, got it? So that is a triad. This pathogenesis is type 1 hypersensitivity. I hope everyone knows what is type 1 hypersensitivity. Now I'm coming on the sputum finding. Just suppose it is a patient of asthma. At the time of the attack, the patient is coughing. So whenever the patient is coughing, the sputum will come, of course. So you have to collect the sputum in a sterile container. You have to collect the sputum in a sterile container and make a smear of it. Make a smear of it. Take the sputum and make a smear of it and examine under microscope. You will get 3 findings. In the sputum of a patient of asthma, I am not doing the biopsy. Please mind my words. I have not done the biopsy. I am taking simply sputum. The sputum microscopy in an asthma patient show triple C. Triple C is the finding. What are the 3 C? Kochman spiral, Charcot-Leyden crystal and Crayola bodies. These are the 3 C you have to notice in the sputum of a patient of asthma. Say yes. In the sputum of a patient of asthma, you have to see these 3 findings: Kochman spiral, Charcot-Leyden crystals and Crayola bodies. These are the 3 C's you have to notice there. Can we go ahead? Are you people there? So what is Kochman spiral, what is Crayola bodies, and what is Charcot-Leyden crystals? So imagine this is the trachea. This is the bronchi. You can see the trachea, you can see the bronchi, you can see the lining of the trachea and the bronchi, and imagine this patient is coughing. When this patient coughs very vigorously, the sputum is coming out, right? So sometimes due to the vigorous cough, what happens? The complete strip of the mucosa, the complete strip of the mucosa come out in the sputum. This is a strip of mucosa that is known as Kochman spiral. Kochman spiral is the complete strip of mucosa which is denuated and coming out in the sputum. That is number 1. Number 2, sometimes one cell comes out, degrade and come out. Individual cell, it is known as Crayola body. So if the complete strip is coming out, it is known as Kochman spiral. And if one cell is coming, it is known as Crayola body, right? And sometimes what happens now, diamond-shaped crystals are present. Due to the eosinophils, diamond-shaped crystals come. It is known as Charcot-Leyden crystal. You can see the diagram. In this diagram, please notice this. Can you see the strip? Can you notice the strip? Say yes if you can notice. So this strip is known as Kochman spiral. Okay, can you see these diamond-shaped crystals? These are diamond-shaped crystals. These are Charcot-Leyden crystals. Okay, diamond-shaped, and Crayola bodies are not shown here. So that is triple C. What is triple C? Kochman spiral, Crayola body, Charcot-Leyden crystal. All 3 are seen in sputum of asthma patient. It is known as triple C in the sputum of the asthma. Triple C in the microscopy. Got it? So please learn the triple C. On all 3 there is a PYQ in various exams. Believe me. So see the first question in front of you. Can you please answer it? What is the correct answer? Would you like to say here? Crayola bodies are seen in. Where does Crayola bodies occurs? Yes. The Crayola bodies are seen in asthma. Of course, the correct answer is asthma. Of course. Late response, okay, this is based on Charcot-Leyden crystals are seen in. Again, the answer is asthma. Again, of course, है ना? And Kochman spirals are seen in Kochman crystals. Again, the answer is asthma, right? So these 3 C are ultra important. Never ever forget. So till now, out of the 4 COPDs, we have completed the 3. Okay, we have seen chronic bronchitis. We have seen emphysema. Okay, we have already seen Kochman spiral, emphysema, and we have seen asthma, and lastly we are coming on bronchiectasis. So lastly but not leastly, we are coming on the bronchiectasis. So let's start bronchiectasis. Can I start? So what is the level? So it is a disease of bronchiole. It is a disease of bronchiole. So let me help you in revision again. Chronic bronchitis and asthma, these are the obstruction occurring at the level of the trachea and bronchi. Emphysema is a disease which is occurring at the level of acinus, emphysema, and bronchiectasis. Currently I am teaching you bronchiectasis. Bronchiectasis, it is occurring at the level of the bronchiole. So you can see the level is different. All of them are COPDs, but they all have obstruction, but the cause is different, the level is different. This is how you have to approach. So the next disease, the last disease we are covering here, is the bronchiectasis. So the bronchioles will get dilated. Can you see the bronchioles? See the upper lung, it's normal. See the lower lung, the same bronchioles, the primary, secondary, tertiary, terminal, they get dilated. They get dilated, right? Why they get dilated? What is the reason? The reason is the infection and inflammation. Infection, inflammation. Infection leads to inflammation. Inflammation again leads to infection. It's a vicious cycle. Infection and inflammation, the wall will become weaker, they become dilated. So infection and inflammation is the reason, right? We have a dilatation of acinus also. The dilatation of acinus was emphysema, but the reason was there was protease antiprotease imbalance theory, and the reason here is the infection and inflammation. Because of infection and inflammation, it become dilated. Okay, so that is the thing. Now listen, it is of 4 types based on the shape. Listen, can you see the shape can be like varicose? This is known as varicose. This shape is known as varicose. It can be cylindrical. Okay, it can be one side coming out, that is fusiform. It is both side coming out, that is secular. Okay, so varicose, cylindrical, fusiform, secular, depending on the shape, it can be of 4 types. And I told you the pathogenesis, it's infection, inflammation. It's a vicious cycle. Gross is unique, very important. It is known as honeycombing lung. Can you see all the bronchioles, primary, secondary, tertiary, they all are dilated. Appreciate the dilatation. They all are dilated. Since they all are dilated, it's looking like a honeycombing. Hindi mein kahun to madhumakhi ka chhatta. It's looking like a honeycomb appearance. It's very typical, important question. It's a spotter. Typical honeycomb appearance is seen in bronchiectasis. Microscopically, you can see the complete bronchiole is dilated and inflamed, right? So that is the thing. Now here I would like to mention a syndrome. The name of the syndrome is Carter-Jenner syndrome. What is Carter-Jenner syndrome and why I am teaching you this syndrome here? What is Carter-Jenner syndrome and why I am teaching you this syndrome here? So Carter-Jenner syndrome is a triad. One of the thing is bronchiectasis. One of the finding here is the bronchiectasis. Let me explain you what is Carter-Jenner syndrome. You know what is cilia and in how many organs human have cilia? We know the lining of the respiratory tract. What is the lining of the respiratory tract? The lining of the respiratory tract is pseudostratified ciliated columnar epithelia. It's cilia. It's cilia. It's like that, you know. So cilia, this is cilia we have drawn. The cilia beat, you know, beating is like that, you know. We झाड़ू लगाते हैं घर में, हिंदी में कहो तो, to remove the garbage, to remove the dirt. We used to clean our home with a झाड़ू, you know. So in which direction you take the dust? From inside to outside the home or outside to inside the home? Of course, we take inside to outside. अंदर से बाहर निकालते हैं. We take the dust out, not in, right? In the same way, cilia have a direction of beating. So cilia beat in a peculiar direction. So whenever any dust particle, any foreign particle enters the respiratory tract, cilia beat like that, so that it will be pushing it out, right? So cilia are very important. If cilia are missing, you imagine what will happen. There is no one to beat it out. There is no one to throw it out. So all the dust, dirt, particles, bacteria, viruses, they will enter and they will cause the infection again. You got my point? Now the cilia is made up of a protein. Inside the structure of the cilia, there is a protein. The name of that protein is very peculiar, and that is missing here in Carter-Jenner syndrome. That is missing in Carter-Jenner syndrome. You got my point? So here that is missing. So that's why the cilia are non-functional, and that is Carter-Jenner syndrome. Since the cilia are non-functional, the lung infections are very common and patients have again bronchiectasis. I told you now, bronchiectasis is due to infection and inflammation. So patients have recurrent infection in the trachea, in the bronchioles, and that will lead to dilatation, inflammation, and that will lead to recurrent bronchiectasis. Number 1. Patient have recurrent sinusitis. Again, the reason is same, because the cilia is missing. The cilia is missing, the patient have sinusitis again and again. You got my point? Can we go ahead? Right? And third, the patient is having situs inversus. What is situs inversus? It is not related to cilia, but a third finding is there. Situs inversus यानी हिंदी में कहूँ तो उल्टा पुल्टी. In human body, where is heart? On the left or the right? Everyone knows, a little bit tilted towards the left side, heart, है ना? Where is liver? Liver is towards the right side. Where is spleen? It is. So we have a peculiar orientation. Some organs are towards left, some organs are right. Imagine you are doing imaging of some patient and heart is on the right side and the liver is on the left side. Oh my God. So the complete orientation is ulta pulta. The left organs are on the right organs are on the left, but you know, relativity is same. The person is normal because the left is right, the right is left. You know, in that person, that is known as situs invertus. In situs invertus, one of the finding is dextrocardia. Dextro matlab right side, cardia matlab heart. So heart is on the right side. So imagine you can see this X-ray. I guess everyone can see this X-ray. What is the peculiar finding in this X-ray? Can you make it out? Can you make it out? I can see like the heart is on the left side. Can you see this is the border of the heart? So it is more tilted towards the left side. I'm sorry, more tilted towards the right side. I can see this is the right side of the patient. This is the left. You all can make it out. This is right, this is left. So this is dextrocardia. Situs invertus is dextrocardia. The liver is on the left side. Everything is reverse. Sinusitis and bronchiectasis, the triad of Carter-Jenner syndrome. So who will tell me the triad of Carter-Jenner syndrome? What is Carter-Jenner syndrome and what is the triad? Carter-Jenner syndrome. What is the problem? The cilia are non-functional. The cilia are non-functional. What is the triad? In the triad, two things are related to cilia. Number one, the patient have bronchiectasis, recurrent infection, sinusitis, recurrent infection, and the patient have situs invertus, in which dextrocardia is the finding. Dextrocardia is the finding. Dextrocardia is one of the finding of situs invertus. So this is known as Carter-Jenner syndrome. These patients are infertile. These patients are infertile. Infertility is not coming in the triad, but learn the fourth finding separately. It is not coming in the triad, but they are infertile. Can you tell me the reason? Can you tell me the reason why they are infertile? The males why they are infertile, the females why they are infertile. Both are infertile. Can you tell me, does anyone know the reason? Yes, the triad you have to learn separately. Please learn the triad separately. Apart from that, the fourth finding, they all are infertile. They cannot reproduce. They cannot conceive. Why? Tell me different reason for male. Tell me different reason. Tell me reason for both male and female. Okay, let's talk about the males. Let's talk about the males. Why males are infertile here? You know, males have sperm. Of course, everyone knows. Sperm have a tail. The tail is like cilia only, right? The tail is also having the cilia. So I'm saying in Carter-Jenner syndrome, the cilia is non-functional. So the tail of the sperm is not functional. So sperms are immotile. I mean to say the sperms are immotile. If the sperms are immotile, how the person can reproduce? You got my point. So let me draw the reproductive system of male and female. Let me draw it for female. In the female, I am drawing the uterus, the cervix and the vagina, and these are the fallopian tubes I am trying to draw. This is the ovary I am drawing, a rough diagram I am drawing. So here during sexual intercourse, the sperms comes inside like this, but the sperms have the tail. Normal sperms are motile, they have the tail. With the tail, they move inside the reproductive tract of a female. It's like this, and from here the ovaries produce the ova, and ova are grabbed by the fallopian tube, and this is how the ova reaches here, and sperm ova fuses, and this is how the patient conceives and reproduction takes place. Everyone knows that, but I mean to say the tail is non-functional. The tail is non-functional. That's why the male are infertile. Why the female is infertile? Ova don't have a tail. Ova don't have tail. Yeah, does anyone know the reason for female infertility? Can anyone tell me the reason for the female infertility? Yeah, ova don't have the tail. So how does ova reach from here to here? Ova don't have tail. How does ova reach from here to here? I'm asking you. Because the fallopian tube mucosa have the cilia. The fallopian tube mucosa have cilia, and that beat the ova in this direction. So this cilia is missing, and that's why the females are also infertile. Yes, very good. So that is the reason. So male, female both are infertile. That is the point. And sometimes the question is asked why they are infertile. You should know that. And learn the triad separately. That is all about Carter-Jenner syndrome. We will solve some question on that. Based on that, see the question, tell me the answer. What is true about Carter-Jenner syndrome? All except. Tell me what is not true about Carter-Jenner syndrome. Can you tell me? Dextrocardia is there or not there, infertility is there or not there, bronchiectasis is there or not there, and mental retardation is there. So of course there is no mental retardation, but other three things are there. Although infertility is not coming in triad, but it's there, right? So tumors of lung, again I am leaving here because I'm going to take all the oncology at one place. So what else you want in pathology? Have you watched my previous sessions of pathology? I have covered entire pathology. In male and female genital system, if you say I will cover the tumors here, but I want to cover. So in male genital system, I want to teach you three tumors. The tumors of the penis, the tumors of the testes, and the tumors of prostate. That's male genital system. That's it. The 3 tumors are there, the ultra important. And in female genital system, again I would like to teach you 3 tumors here: the tumors of the ovaries, the tumors of the cervix, and the tumors of the uterus. That's it. So 3 plus 3, 6 tumors. So basically I'm planning to launch a oncology series in which I'm going to cover the important tumors. First I will teach you the brain tumors there, then in bone tumors, all the bone tumors I will take. Okay, I will take brain tumors, bone tumor, lung tumor, renal tumor, male genital system के tumor, the 3 tumors I taught you, that is testes, penis and prostate. The female genital tract के tumors, the 3 tumors I told you, ovary, uterus and cervix. What else? Anything I'm missing? Gastric, like the GIT tumors. GIT tumors में stomach का tumor, intestine के tumors we will see, and esophagus का tumor of course. Anything else I'm missing? Thyroid. We will cover thyroid tumors, all the 4 thyroid tumors. Anything else I'm missing? Yes. So these are the important tumors we have to cover in the entire pathology, what I can remember. If I'm missing anything, you can let me know. Right. So the oncology series, all tumors at one place. Maybe it will take another 3 hours, another 3 to 4 hours. So back to back, only pathology of the tumors. I will not teach you the treatment part, the chemotherapy part, the radiotherapy part. No, it's not my subject. I will teach you the pathology of all of them at one place. The gross of all of them, the microscopy of all of them, the classification and the staging of all of them. Right. Say yes. So do you want this session? Yeah, breast I have missed. Very good. The breast tumors we can cover. Anything else? Important tumors which I am missing. I can cover ENT ophthal tumors also if you wish, but they are covered more importantly in ENT and ophthal. If you want me to cover nose and eye, in the eye I can cover retinoblastoma, the important. I cannot cover all eye, but the retinoblastoma I can cover here, right? In the ear we can cover the important one, not very this thing, but the very important thing. In the nose we can cover the rhinoblastoma and all. So we can cover ENT and ophthal also if you wish, otherwise, and we can cover larynx tumor also, right? The tumors are unlimited, but pathology point of view, these are important. So you want the series, when you want the series, we can launch it soon. Skin tumors, we can do so. In the skin, only 2 tumors I teach, only 3 tumors: squamous cell carcinoma, basal cell carcinoma and melanoma. The most important is the melanoma here. Skin tumors we can cover. Anything else? So we can cover all these tumors. So if you are increasing the bulk, instead of 3 hours, it can be 4 to 5 hours also. If you want gross, microscopy, classification and staging, that's it for all of them. So from pathology point of view, and many tumors are overlapped. So FGT you will cover in gynecology also. They are covered there also, right? ENT tumors are in ENT also. Ophthal wale in eye also. So multiple subjects are correlated here. So, but if you want me, I can take. Skin tumors are covered in derma also, right? But yeah, oral tumors, nothing important. No question will come from the oral tumors. Oral tumors only squamous cell carcinoma, that's it. But yeah, I can tell you the important sites and all. Histology point of view, nothing important. So we can cover all tumors soon. I will ask the team, the same ProCM team, I will ask them to arrange my session on the same YouTube channel for the oncology. If you people also demand, if you want, you can write down in the comment and we will ask the team to organize the session, the pathology, oncology tumors. Oncology, pathology of all oncology. Okay, so that can be the title of the session and we can cover all tumors. So here I am not covering the MGT because it is the tumors and it will be a repetition. MGT, FGT and bone tumors are there, the next slides. So we can cover another session. Currently, I would like to end the session and we will cover entire tumors at one place. Thank you so much. I hope the session was good for you and we can plan it soon. Okay, so okay. So I will discuss the team and let you know. And the PDF I will share with the team soon and you will get it on the Telegram group of ProCM only. So please, those students who have not joined the Telegram group, please join the Telegram group of Dr. Bhanu Prakash sir, that is ProCM, and I will share the PDF, the annotated as well as non-annotated there only. Thank you. I hope you like the session and all the systems are covered now in entire systemic pathology. If you have missed the previous session, I request you, the 3 previous sessions available on the same YouTube channel, please watch that. The entire general pathology, the entire hematology, the entire systemic pathology part 1 and this is part 2. So if you watch these 4 sessions of entire pathology, the entire pathology is covered and all the questions in your exam, if you are targeting FMG or NEET PG, will be from this only, that I can assure you. You can solve any MCQ. If you are preparing for your MBBS university exam also, you can do well in that also. Thank you. See you. Bye-bye and good luck. Wishing you all the best. Hope to see you again. Bye.